Hospital in London. Are we up and running there?
Yep.
Ken Sleep, if you guys have got some questions for Dan at any point in this thing, you can call me and we can ask them for you, put them on the speakerphone, however you'd like to go. So I guess we could go in and have people introduce themselves here. Dan, so you kind of know who your audience is. We'll start here with this young man from Laramie.
All the way from Laramie.
Yeah. You want to introduce yourself, Tyler, and your position, or however you see yourself in life?
Well, you run our crew.
I mean, yeah, I'm Tyler Day. And
Very
we
good.
met before at the hospital when I was working with Ed.
Yeah.
EMT basic. Yeah.
Cool. Nice to meet you.
Such a dork. I'm Amy Kay. I am an EMT and I teach at the middle school, science at the middle school.
I'm Mandy Wilson. I'm an EMT and I work for a roofing company.
Mandy used to do a lot of drug things. Which
What's
is with
Brandon
the fire
doing?
police department.
Okay.
I don't have a job, I don't have much luck.
Whatever.
I know this character.
Hey, I'm Charity. I should know you.
Yeah, we met.
Yeah,
We
a
met.
few times.
I feel like I've seen everybody at least once.
Yeah, I bet you, I didn't know you were a pharmacist though, that was interesting. Yeah, Jim Lash, I'm retired. That's a good job to have.
Yeah, I was gonna say that's where I'm headed.
Though my performance review by my wife might be down a little, we'll have to see.
Evaluations need to be addressed, huh?
Yeah, job performance thing is crucial.
Evolving, you gotta get better at
Do I
that.
have to collect a retirement to claim that I'm retired?
Yeah, no. I actually had a seminar on how to clean the bathrooms appropriately here a week ago.
That is
Well,
and certainly going on
in the
there.
comments she wrote, should go back to work.
In the comments was, shows promise, however, deficient in numerous areas.
Brennan and
Teach
Lori.
that seminar at my house.
Well, hey, Dan, I'll turn it over to you. Mark doesn't want to talk today, and London's busy, so.
I'm London. I teach at the high school science. Yeah.
Cool. All right, so like you said, I'm Dan. I'm a pharmacist. I will do my best to help you guys out here. I'm not a teacher by trade, unfortunately, so like I said, I'll try here. Have you guys already read chapter 12, or are we starting from scratch here? So you guys are pretty familiar with it?
Read it.
I said we
We
read it.
read it.
So you
None
okay.
of it makes sense, but
Let's not go too far.
All right.
I'm not sure I want to test over it right now.
Fair enough. Okay. So I was looking through the curriculum here that I got, and I kind of think I want to start out of order a little bit, just because I think there's some terminology and some concepts that are very helpful to understand before we try to get into the material, and then that way it does help you guys a little bit. So I want to go through the terminology and definitions. I'll right off the bat to make sure we have that. So I'll ask you guys, if anybody knows it, you're welcome to chime in, and then if not, we'll talk about it. So drug terminology, which I have is section 6. I don't know how that correlates to the book.
It's probably the, at the end of the chapter, there's a, or no, there isn't for this one.
It says the section number on the top of the left page.
Yeah, it goes to section 5, so.
Yep.
It makes sense.
Okay. All right. Well, I'll ask them out loud if you guys can find them. I think they are towards the back of the chapter. I've ever seen them. Antagonism. Are you guys familiar with that?
An antagonist?
that's one that
Yeah.
goes
Usually goes to
against.
Exactly. Yeah. So.
Is there like a protagonist? I mean,
Yeah.
Kind of, yeah.
Yeah.
it's the idea that you give something. I know when my son tranquilizes animals, they give something to reverse it, but it's an antagonist or a.
Right. Yep. So usually when you're referring to antagonism or protagonism, you have a receptor, and in some way the drug will cause an effect by stimulating or blocking that receptor. And so antagonism would be like anti, And so you're going to stop that receptor in essence, where protagonism will be stimulating that receptor to cause a stronger effect. And so with a lot of medications, you'll see like, for a very simple example is with diarrhea, you want to stop that. And so you can give an anticholinergic, which is an antagonist of the cholinergic receptors, blocking those receptors, stopping diarrhea. So that's a pretty easy one, but just keep in mind, so if you're antagonizing, it's anti, you're stopping whatever that receptor is doing. If you're pro, you're supporting it, and you're gonna stimulate it and lift that up. So, and just a tip, a lot of words in medicine in general, if you can break them down and kind of see the like subparts of the word, sometimes you really don't need to know what the word means, but you can kind of get the gist of what's going on. Okay, so a bolus. Anybody familiar with that term?
Say it again?
Bolus? Like IV bolus, maybe?
Bolus.
So,
Bolus,
yeah.
It's
So
like giving a quick shot of something.
Mhm. Exactly, yeah. And generally, you're going to probably talk about intravenous fluids there. And in medicine, whenever I refer to bolus, it usually means I'm giving a bulk of fluid rapidly. And usually that's in critical situations, whatever, it's going to help support that person. Contraindications?
Something that
Something
you,
that tells you not to do.
Exactly, yeah. Yeah, so those are the things that you don't want to do. This medication is contraindicated to these states, so you don't want to combine them. In medicine, you'll see absolute contraindications and relative contraindications. And that's just, there's some things that it just comes down to provider discretion, that it's all risk versus benefit, basically. And there are some things you're never going to get more benefit than the risk, but other things, depending on the person and the situation, maybe that contraindication isn't an absolute. Yeah. Cumulative action, I think that's another instance of knowing the small pieces, yeah, so it's just building up. Depressant, is everybody familiar with that one? Where you're
slows the
suppressing.
body systems.
Habituation, I think we all understand habits. Hypersensitivity is like allergies, or I would even maybe relate that to some people. When it comes to metabolism of medications, I've heard my mentors in the past refer to it. Some people are like horses when it comes to metabolism, and then other people are like maybe like a smaller cat or something like that, where the same dose in two different people causes two drastically different effects.
As similar to alcohol.
Yeah.
Some people can tolerate more
Tolerance,
than
exactly. Some medications you can develop tolerance just like alcohol.
Even though you have the same amount in your bloodstream,
Yeah.
you're able to operate.
Yeah, and it's just, there's a lot of different reasons, like it can be tolerance, it can be, receptor affinity, metabolisms, there's a lot of different factors, but usually this is referring to like an allergic reaction, but you can be overly sensitive.
We get people that have built up a tolerance to alcohol where they drank enough. I mean, is that something you build over time, or is it something you just naturally have?
Yeah, so usually it does come with time, and then for most people, and then it can be either you are damaging receptors, so you're not getting the same effect, so it takes more, or receptors can become less sensitive, and so it takes more to stimulate those receptors. I think in the alcohol situation, I think it can become less sensitive, and so it takes more and more and more to get that same effect from your receptors.
So could hypersensitivity then be because of more receptors, or just because they react?
I'm not going to say no,
Okay.
but I don't really know as an example off the top of my head that would correlate to that, but it's probably possible. But, so just, I guess keep that in mind what we're just talking about with the drug receptors, but I think overall when you see hypersensitivity, I'm going to be thinking about that person's they're probably referring to somebody being allergic to that medication, and that they're going to have an allergy from being too sensitive. Idiosyncrasy.
Not in sync?
Yeah, exactly. And so usually I think what they're referring to probably there is there's not really a correlation that we can establish. And so like in the case of the new COVID vaccines, I'm sure you guys have seen the cases of like Bell's palsy and whatnot. And so what they're trying to decide is that like an idiosyncratic reaction where it's a reaction but it has nothing to do with the vaccine? Or is there actual correlation where there's something going on there with the vaccine?
Is that the one that allows the doc to justify the bill without having to say, I don't know?
Maybe. All right, so an indication.
Something that says this is what you need.
Yeah. In medicine, it's the usually the labeled uses are so lisinopril is blood pressure medication. So if somebody has hypertension, that's an indication for lisinopril. Potentiation, that's kind of like cumulative action, where one thing is going to potentiate an effect that's going to cause an increased effect. Not a word I use very often.
You know, it's interesting, we run into a lot of people in the ambulance that have gone to multiple doctors, and they had multiple prescriptions, and the doctors didn't always know what the other doctor had prescribed,
Yeah.
and someone's taking something else, then they have a combination reaction. Is that similar, or is that?
Yeah, that could be, like, one drug can definitely potentiate another, and so a lot of drugs are, like, we'll take liver metabolization. There's enzymes in your liver that are breaking everything down in your bloodstream, but especially some medications. And so sometimes drugs will, let's see if we can combine some of these. Like, you can get protag. So one drug will be metabolized by this enzyme, and then you can take another medication that will be a protagonist of that enzyme, and so it can speed that enzyme up, which would, and could do either thing depending on what the enzyme is doing. It could cause less or more effect of the first medication. And so, yeah, like, there are multiple reasons why you could get potentiation of one medication from another medication. And sometimes it's as simple as, you know, your kidneys are clearing, but whenever you put two medications in the mix, well, your kidney can still only clear the same amount per time. And so then you get buildup and more prolonged or increased effects. So there's a lot of scenarios where, just like that, you can run into that. And so, and that's, for EMS, that's a really good thing to keep in mind, because I see that a lot. American medicine is not very good at communicating with each other sometimes, you know, and so when you do go to multiple doctors, sometimes the patient forgets to tell their new specialist that actually I already see somebody for my diabetes, and the specialist just takes it under their belt because they see that they're not under control, and the next thing you know, they're on twice as many medications as they need to be. And so, you know, maybe the patient's just non-compliant with the first doctor at that time. And so a lot of things to keep in mind, but it does happen a lot. They use multiple pharmacies, multiple physicians. There's a lot of room for those mistakes, especially with patients who aren't good historians. So let's see. Side effects, I think everybody understands that. That's, you know, when you get an adverse effect to a medication that you take. Stimulants, they are the opposite of depressants, so they speed you up. Synergism, anybody familiar with that term?
Yeah, synergy is like the interactions between different aspects.
Yeah.
So I would assume related to this, it'd be interactions between drugs, how they work together.
Yeah, and I think exactly. I like that last part where you said where they work together. I think that's a lot of it. So, like, blood pressure, you start with first line medications and you max that medication out when you still, and a lot of people don't get enough effect from that, and so then you'll use another blood pressure medication, you'll start titrating that up. And usually within three medications, you usually have it fixed. I don't really like to go to 4. But that's an example of synergism, where you have these 3 medications working together towards the same effect.
So would synergism then lead to potentiation? I mean, they seem very similar.
Yeah, they do. You're right. I think you could definitely correlate those two terms. Therapeutic action is just the therapeutic effect from a medication. Tolerance, we've talked about that a little bit. That's just where the result becomes less and less and less. And so I usually think of habituation, tolerance, and even the synergism and potentiation with opioids. Are you guys familiar with opioids? Yeah, I think everybody's had, in some form of way in their life, those have probably.
We don't have any with us right now.
Good. Good. That was a trick question. Good. So, you know, opioids, like alcohol, the more you take, the slowly less effect you get. So you have to take more, and then, you know, the habituation.
Suck you in.
Yeah. So that's where that comes into play a lot. I have an untoward effect here, which is not a term I use. I'm assuming that's an unintentional effect, but if that comes up, we'll talk about it again. Okay,
Actions that can be harmful to the patient.
good, yeah.
That's the definition of the book.
All right,
It's called untoward?
yeah.
Untoward, yeah.
Untoward? Untoward.
It's unintended in our book.
Unintended.
Oh, okay.
Where,
I'm just going through the glossary.
that's what I was looking at. I was in the-
Well, what page are you on?
Oh, there, okay.
And the school teacher comes out.
Come on, kid.
All right.
Tangerines.
All right, I'm gonna go to section 7 on my handout here, which is pharmacological concepts.
Principal's office.
I did not print that handout for everybody, I apologize, I will get those to you.
Yeah,
I think
following
I think I
along.
sent it out in a
Yeah.
email, but I didn't print it for everybody.
I see, on page 560, it talks about pharmacokinetics and then pharmacodynamics on 563. That's,
That's kinda where
those
we're hanging
pages
out.
there are some of what we're gonna be talking about.
Okay,
I don't know that does this come from this book?
no correlation.
No, it comes from the national NREMT.
Okay, so it may not correlate perfectly.
No, I actually sent that out in a file, but it's like 160 some pages total. I
Okay.
don't think anybody's
I didn't print it.
printed it off, and probably not, it's just for me, so I don't know if they really look at them or not, I hope that they do.
So what I'll do is I'll kind of go through this handout in a way that I think makes sense for understanding principles that you need to build on. And then if you guys want, we can go through the chapter too. I mean, I'm free, so we can, and that'll kind of hit it twice too, so it may kind of reiterate a lot of what we talked about.
That sounds good.
All right, so pharmacokinetics. Has anybody heard that term before? Okay, so
Not since last night.
not since last night. Pharmaco is pharmacology, obviously. Pharmacy. Kinetics is sort of like math and physics combined inside your body when you put this all together. So this is how your body is moving, using what it's doing with your medication in a objective, number-oriented manner. So these are like, well, I guess we're probably going to talk about a lot of this. So exactly, absorption. So as a pharmacist, I want to know how fast does it take to absorb a medication? How well do we absorb medications? And then that way I know like what the onset of action is. That's very important because a doctor gives a medication with an onset of action of 24 to 48 hours. In 6 hours, they're looking for that effect, and they're like, Dan, why is this not working? We need a new medication. Well, actually, doc, we don't. We need to wait till tomorrow, and we'll see what we're looking for. So that's important. Also with absorption, we're probably going to come back to this too, but let's talk about routes of administration a little bit. What are some medication routes of administration that you guys are familiar with?
IV.
IV, good.
Sublingual.
Sublingual, good. I think I heard oral.
Oral, yep.
Yeah, okay. IM, good.
What's IM?
Intramuscular.
Okay,
Yeah.
thank you.
So that's like your flu shot. What was that?
Interosseous.
Yeah, good. That's in your bone. Thankfully, I've never had one of those.
Rectal.
Yeah, I
Yeah,
was gonna say that.
yeah, good.
That's okay.
The patches on your skin where they.
Transdermal.
Transdermal.
Dermal.
Yeah. So dermal is your skin layer. So trans is across the skin.
Gosh, I'm forgetting sometimes.
Drops in your eye,
Eye drops, ear drops.
The nasal.
Intranasal. Sort of new Narcan, right?
Or
Like
arrow,
nasal.
like preventable.
Yep. Inhaled. Inhale. Okay. Yeah. There's subcutaneous too. Anybody know what subcutaneous is?
Under the
Sub-Q, just under the skin.
Under the skin, right? So,
Transcutaneous.
transcutaneous. Yeah, that would be probably like transdermal. I would say those are about the same thing. Yep. I feel like
There's one that, like, it wasn't sublingual, but like between your cheek and your
transbuccal.
gum. Trans what?
Buccal.
Transbuccal.
Yeah.
That was one that caught my attention.
BUCCAL. Yeah. So there's a lot of different routes. Does anybody have any idea like why might we choose one route over the other?
Speed.
According to this
Yeah.
handy little table.
Onset of action.
Speed, yes.
Speed. Okay. There's a lot of other reasons too. Anybody got any?
What
Access.
system we want-
Access, yep, if they're unconscious, you can't give them to swallow a pill, right?
What system we want it to affect.
Yep, good. Some things you don't want to affect the whole body with, you just want local effect, and so you gotta keep that in mind too. So, or you want the whole body affected. Other reasons would be metabolization, and so like, some medications you put them through the GI tract, and your GI tract will break them down before they ever get to your body. A great example of that is insulin. Like, why do we always have to take insulin shots if we could just drink it, right? That'd be way easier, but you can't because it won't make it to your bloodstream.
Oh, okay.
So, yeah, that's a big one is metabolization because it has to be absorbed through the GI tract. There's other medications like potassium chloride. When I have a hypokalemic patient come to the ER, I would rather see them get oral if they're PO tolerant because it's actually better absorbed through GI tract than it is through the vasculature. And you're looking to just correct a electrolyte deficiency. There's a lot of other things when it comes to, especially injections, where like, a lot of times you don't have IV access, so IM and sub-Q can be useful.
Oh, IO is one, is on this list that they recommend in the book for you.
Yeah, intraosseous, yeah. We use that occasionally in the ER, and that's probably one of those last resort routes, because usually they're drilling.
Here, Amy.
I think you should let me practice one of those.
Yeah, so, yeah, just keep in mind there are a lot of reasons. Usually it's speed, metabolization, or transdermal. You'll hear about fentanyl patches. Everybody's heard of those. For chronic pain patients, it's simply because you can get a very steady absorption for 72 hours. You get this constant rate of absorption. And A, you don't have to take pills every few hours. And B, with pills, you get this absorption curve that looks like this. Patient's good, then they're in pain. They're good, then they're in pain. And then a lot of times with pills too, the other problem is that slow onset of action. You take a pill, and I don't feel better yet. I'm gonna take another pill, and then I'm gonna take another pill, and then all of it comes on, and next thing you know, then you have this potentiated effect, and it can be too strong. So where that fentanyl patch as a prescriber for somebody who needs a lot of medication can be a really nice steady way to do that. So creams, paste, topicals, all that kind of stuff can be really good for local. Because you don't want systemic effects across your body. So when I say systemic effects, I mean through your entire organ system is what I'm referring to. All right, biotransformation. Did anybody see this term when they were reading? I want to make sure I tell you that right.
Biotransformation.
It's on page 562.
I see it.
Good job.
Look at you go, Jim.
Yeah,
I read
this
this.
guy studied.
Well, I did too, but I don't remember any of it.
Don't drink and read.
Okay.
Biotransformation, yeah.
So
I didn't
they're
drink
defining it. Their definition is the chemical alteration that a substance undergoes in the body is known as biotransformation. And so that sometimes you don't necessarily want biotransformation depending on what the medication is, and so maybe that, like in the case of insulin, would be a reason to give it sub-Q as opposed to PO, because you don't want it to be transformed, because then it would be ineffective. But then there are other medications. Who's heard of Plavix or clopidogrel? Yeah. So it's an antiplatelet drug. I would say like a stronger version of aspirin, in a very simplistic way. But anyways, it's a prodrug. Has anybody ever heard the term prodrug? So what a prodrug is a drug being taken to your body, and as in that form, it doesn't do anything. But when it's metabolized, it becomes an active metabolite, and that active metabolite is actually what causes its effect. And so in that case, you want biotransformation.
What would be an example?
Like clopidogrel, Plavix. So Plavix, when you take it, it gets metabolized by your liver, and then that metabolite is what causes the antiplatelet effect. Yeah, and then that metabolite is then broken down again and excreted. So that's the best example I have off the top of my head. There are several drugs that are prodrugs, and that can be, something to keep in mind is like people with liver failure, people with kidney failure, so liver and kidneys are the two main forms of metabolization. And so people that have, again, like we're all different metabolizers. People who have those poor kidneys, poor liver functions, they may not be able to metabolize as well. And so maybe they don't get the full effect of their medication. Children also are a little bit unpredictable when it comes to metabolization. So one of the things that, I don't know if you guys know this, codeine in particular is really not supposed to be used in kids under 18 years old. And so codeine is an opioid. Essentially codeine is metabolized into morphine. So the problem with kids though is that they're a little bit unpredictable in how they metabolize. And so codeine being a prodrug, so it metabolizes into the active ingredient, which causes the reduced pain, analgesic effect. The problem with that with kids who you don't know how they metabolize is that you give them codeine, they don't have any pain response because they're not metabolizing it into the opioid. And then you give them more, and just like we talked about, the potentiated effect, you can overdose children really easy with codeine because of the unpredictable metabolization. So it can be really important. Yeah. Now that doesn't mean, like, you will see codeine used in children. Like, you can definitely use it. It's just something as a provider you have to be very aware of what you're doing and why you may not see that rapid onset of pain relief that you would see with other medications.
You know, it'd be interesting, and I'm sure this is not a recommended use, but like something like Narcan, does that react differently with ages? Or, I mean, if they've taken in its
so,
it probably wouldn't be.
in my experience, Narcan is a really pretty quick acting drug.
So like for an opioid?
Yeah, so used for opioid overdoses. Yeah, I mean, it'd be, as far as I know, I guess you don't really, well, in my career, I've never seen any children overdose on opioids, thankfully. So I've not had a lot of experience with that. But I would expect to see similar effects in children and adults, just what I know about Narcan. But and the good thing is it happens fast. It doesn't need to be metabolized to work. Narcan's one of those drugs that you just put in your body and it does its job right.
So it's just going to go
yeah,
regardless of.
Yeah, as where these drugs I'm talking about are the ones that need to go through your organ system before they do their job. So
What happens if you use Narcan and it's not an opioid overdose and you?
pretty much nothing.
Nothing.
Yeah, so you
So it
can
wouldn't be
do.
something that is detrimental if you, it's
No,
not
it-
opioid overdose and you give it, they're not gonna kill somebody.
So, two things. So Narcan is a opioid reversal agent. It's an opioid antagonist. Okay? And so you give small doses, 0.4 to 2 milligrams, and you repeat every, I believe it's 2 to 5 minutes, up to 10 milligrams. And that's because at 10 milligrams, no matter who you're treating, if it's opioids, or at least 100% opioids, you should be seeing a result. And at that point at 10 milligrams, if you're not getting the benefit you want, you're seeing no improvement, you just need to stop because it probably is something different. And then my second part, I was gonna tell you, I kind of forgot. But let's see, what was I gonna say? It was good, it was important.
I'm sorry I took you off topic.
No, you're
Narcan.
good. You're good, this is good, it's worth talking about.
I just know that's one, is that one that we could potentially be using?
Yeah.
So I wanna
Yeah.
make sure that.
So, okay, what happens if you give too much? Really nothing, and that's why that 10 milligram stop limit is in there. Because it's common that it could be other things, hypoglycemia, maybe there's benzodiazepines on board, which are suppressants, or depressants, I'm sorry, that's the right word. I think there was something else I want to tell you guys about that, and I think it'll come back to me.
Okay.
So, I know that there's different routes for Narcan.
Yep.
Like, what's kind of the deal with that?
I remember now. Good job, good job. Okay, so there are multiple routes. I think like when you guys are in the field, maybe you don't have IV access yet, and time is of the essence. Also, Narcan is now OTC, right? So at least, I'm not 100% sure in Wyoming, and I'm sorry, that's my fault as not being a retail pharmacist. Most states, you can get Narcan over the counter as an individual. You have to fill out a little bit of paperwork, but then you can carry it and administer it to somebody in opioid overdose. So they've deemed it over-the-counter safe, which, as an EMS, is pretty low risk. That means that the general population can use it and not hurt anybody, is the ideology there. And so, for the general,
it is in Wyoming.
it is good. Thank you. For the general population, they're not going to be able to start an IV, right? And so their intranasal becomes really beneficial. Even in the ER, maybe we have somebody coming out of surgery, and they usually have IV access, so you can use IV. But you could also use a nasal atomizer, which is a device you put on a syringe and it just aerosolizes the Narcan for nasal.
That's what they're recommending.
There's a picture in
Yeah.
here on, I forget what page it is right there.
Do they have to be refrigerated or anything?
No, it's just room temp.
Cops carrying around in their pocket.
Yeah, pretty much. People just keep it in their purse. Police officers nowadays are carrying it in a lot of cases. Yeah, so that's kind of why it just comes down to like, what's the best thing for the situation.
That makes me feel better.
Yeah. It really is pretty safe, right? And so, it's an antagonist to opioids, and so if you don't have opioids in your system, it's not really gonna do anything. Yeah. And so that's why, if you aren't seeing the effect, you're probably dealing with a different situation. Okay. Let's see, metabolism and excretion, we kind of talked about this. Kidneys, intestines, lungs, endocrine glands. I would say more than 90% of medications as far as metabolism goes, I'm thinking about kidney and liver. It's common, especially in our older population, to see like compromise of both organ systems, especially kidneys. As you age, we use an estimation called creatinine clearance for kidney function, and as you age, your age is part of that calculation, and so it just naturally goes down. There's some labs we draw as well, but I mean, keep in mind that like a lot of medications dosed appropriately are fine, but you know, patients have acute changes in their kidney function at times. So you can have acute kidney injury, and so you may be fine when you're at the doctor, but maybe this medication that's renally cleared has some sort of negative effect on your kidneys. It can cause a spike in your creatinine, which would cause a decrease in your kidney function, and you could get an accumulation then. And so some medications can cause cognitive disabilities and whatnot. So if you have a short-term lapse in your kidney function, you could see those side effects break through. One that really comes to mind is fluoroquinolones. Have you guys ever heard of those? Levaquin, ciprofloxacin, levofloxacin. Those are an antibiotic class called fluoroquinolones. They're used a lot, especially for, we tried not to use them actually, but they are used still somewhat frequently. They are renally metabolized. They can cause cognitive effects, and so you could easily have, especially the elderly, have an acute change in renal function, which could be just driven by dehydration, which is super common. And then next thing you know, the next day they're having some sort of cognitive defect because of this antibiotic on board in combination with poor renal function. So
like when my grandma would get bladder infections, she would be like totally loopy.
yeah, and that could be the antibiotic. It could also just simply be the infection, because that's also common. So you guys may come across that, disoriented patients.
Yeah, fairly often.
Yeah. So there's lots of reasons, you know. It may, if you know their baseline, that's always very helpful, and that's one of the first things I would be asking is like, if there's anybody around, like, is this normal for this person? Yeah.
Typically when we find them, they don't have any clothes or anything else. Right, Tyler?
Talk about it, Jim.
That might be more than the antibiotics.
Probably not due to the antibiotics.
Sometimes it's a combination of things.
They call the ambulance, they know it's our crew, and they strip.
Jim's coming.
And part of the problem.
All right, so that's pharmacokinetics. Pharmacodynamics. This is a very similar related concept, and I mean dynamics, pharmacology, it's the dynamics of how what the medicine's doing in your body. So mechanism of action, that's just like it sounds. It's what mechanism does this drug use to exhibit its action on the body. So we talked about receptors already. There's the agonistic effect, the antagonistic effect, and then two other concepts we want to cover are affinity and efficacy. So all medications they have to get to your cells, right, to cause an effect, or to a substance, right? So generally, this is going to be a little bit of like medicinal chemistry almost. The medications we're putting in our bodies, they want to go to the cell and bind to a receptor, or they want to go to the opioid that's circulating in your system and bind to that. So we're always looking for this chemical interaction throughout our body, or yeah, it's always in our body. But then that reaction is gonna cause whatever effect we want, like we talked about. It's gonna antagonize a cell or protagonize. So another word for protagonist would be like an agonist even. So those words mean the same thing.
That
They're
was a
just
word they use in our book is agonist.
agonist, okay. Good. And so just keep in mind it's either it's causing an effect or it's stopping an effect, whatever that might be depending on the situation. Affinity is how strong is the attraction for this medication to that binding site, whether it be the drug that's in your system that you're trying to reverse or those cell receptors. So, and that affinity kind of, it does a lot of things. Sometimes you can get like absolute binding where that cell or receptor is completely inhibited, or sometimes it's not absolute and it'll come off in a certain amount of time basically. And so and what that results in is like some medications will have longer durations of effect, or maybe it's just a few minutes. If you stop giving the medication continuously, then that receptor is unblocked. So one of the things that comes to mind that we use in the ER a lot is nicardipine. Have you guys heard of that before? Okay, so it's a calcium channel blocker similar to diltiazem maybe? Is that one familiar? Okay. We use it for hypertension and maybe like stroke patients. The good thing about it is it has a low affinity, and so it will, you put it, as long as you're giving this IV, it's keeping their blood pressure down. But if it goes too low, or maybe they hemorrhage or whatnot, then you can shut that IV drip off. The affinity's low, the cells become unblocked, and the results are gone within minutes. And so that's a huge advantage than if I chose there's calcium channel blockers, same drug class, that have higher affinities, longer durations of action. If I chose that medication and the same things happen to that same patient, it could be like lethal, essentially, because you can't shut it off and stop it fast enough to fix the problem. So that can be pretty important whenever you're dealing with those emergency situations. Anybody familiar with what an enzyme is?
I should be.
Yeah.
Yeah?
London is.
Yeah, we got a science teacher.
She teaches that.
Yeah, I don't teach enzymes.
Okay.
That's about the.
I mean,
All right, so an enzyme.
They just assist with like chemical reactions in your body, right?
Yeah, in general, an enzyme is like they're breaking things down, okay? Typically, and a lot of times it's proteins. Kind of think of it like, man, what's a good way to describe it? Yeah, I mean, essentially that's what it is. It's breaking things down, whether it be proteins or medications or whatnot. And so like in your liver, it's full of enzymes that are, one, just filtering your blood on a normal daily basis, but then two, when you put medication in your body, those enzymes are responsible for the metabolization of that medication. So whenever we talked about the prodrug, like codeine, it's metabolized by enzymes into the active metabolite. In my mind, like very simplistically probably, I think of enzymes like they're like little garbage disposals, or like a food processor in your body that you're throwing this medication at and it's blending it up into the active form and then sends it out to work. Or the active form comes in, it gets broken down and sent out as inactive to be excreted by kidneys or in your urine, whatever it might be.
So there's some kind of an enzyme effect that's looked for in blood labs that helps somebody determine whether you've had a myocardial infarction or something?
Does
that
yeah.
sound any?
So
in the labs, it apparently will show up and tell you if you've had an MI,
yeah.
or if it's some other issue. If that's not there, it tells you maybe it's not an MI.
Troponin. Yeah.
What is it?
Troponin.
Troponin? Okay.
Yeah, and man, you're right. That is right. So I think troponin is a cardiac enzyme, and so whenever you see increased elevations, anytime you stress anything, it creates like waste product basically. And so in an MI, your heart gets stressed from lack of oxygenation, lack of blood flow, and so it releases. I don't want to tell you guys wrong. This is a little bit on the edge of my scope probably, but it's essentially, I'm assuming you're releasing waste products, and then I don't know if how the enzymes correlate with that release, but they definitely become increased or elevated with that stress, and so that's part of that mechenism
Pretty much
somehow.
they don't want to see
Yeah,
And then
usually.
If it has, that means there's been.
Stress, yep.
I just got my troponin levels checked.
Okay, good.
So like they were checking to see if there was any kind of stress on my heart, and if it's 0, you're good. But if it goes up just a little, they're gonna send you out.
Yeah, because it is showing stress on the heart, which is, I mean, stress equals ischemia, which is blood and oxygenation loss causing muscle death, and muscle death, your heart's a muscle, so you want those cells to be strong and healthy. Does that answer your question?
Yeah, but that is the enzyme though.
Yeah.
How it.
Yeah, let me
works
just
on
double check that
metabolism.
real quick.
Trying to help myself understand this concept.
Yeah, and this says that troponin is an enzyme for cardiac arrest, and it's one that shows up during cardiac damage.
Good. Yeah, the part that I don't remember as well is what causes it to elevate, because the enzyme's there, and I think your body just must start producing more enzyme due to that stress, and I'm assuming it's because of the byproduct of the myocardial infarction, the waste products.
Okay.
Sorry, I'm not super clear on that mechanism of action, but do you guys have any providers coming, Jim?
Oh, yeah, we will. We'll have
Yeah,
some
they'll go
docs
over
here.
that.
That'd be a good question
Yeah,
to
they'll
bring
go
up.
over that.
Okay.
They were.
Cool. All right, so that's good. Medication response relationships. So plasma levels, what's plasma?
It's the clear fluid in your blood.
Yeah, okay, good. So,
Is there a question?
basically, that's as simple as it sounds. It's just measuring the level of medication that's in circulation at any given time. And so, some medications are more critical than others. Some we don't have to worry about. We just know the effect is, within reason and gonna be safe. There's other medications like warfarin, maybe. Has anybody had any experience with that and doing INRs? So we're checking the.
Killed my mom.
Yeah.
Her INR, she was a hypersensitive, and like she'd go from like 0 to 8, then 8 to like 2, then.
Yeah. Warfarin's particularly tricky because it has interactions with food, it has interactions with alcohol, medications. It's very, very sensitive to metabolization, and anything that either agonizes or antagonizes its metabolization.
So that's the blood thinner. I think that might be the one my sister's on too.
It is a
'cause
blood
she has
thinner,
to be
yeah.
careful about what she eats.
Yeah.
Or it'll
No
make an extra thing.
green.
Right.
Like, it's vitamin K.
It is, yes.
Just had a light bulb. So when my mom was on that, I remember that being warned that she shouldn't do the green leafy stuff, and now I understand why.
Yeah, and the most important thing is even that it's not that you can't do anything, but whatever you do, you want to do consistently for this same consistent interaction, and you can adjust for that. What you can't adjust for is the person who never drinks that goes and binge drinks on Friday night, or never eats a salad and then eats salad 3 times in the same day.
Healthy.
Yeah, that's really hard to account for. So, basically that's it. Plasma levels is.
So are you saying binge drinking's not okay?
I would say
As long as you're not on warfarin.
Consistently,
Okay.
every night, you'll be fine.
Sorry, I
That's a whole
digress.
different topic. If anybody's on warfarin, come see me after this. We should talk.
Sorry.
Oh man. All right. So biologic half-life. Who's familiar with what a half-life is? Yeah. Okay. a few
Kinda.
people.
I'll
Oh, you wanna
teach
give us
that
a
either.
definition?
I mean.
Do you remember what London
Yeah,
taught you,
yeah.
Logan? Tyler?
Yeah,
Or
Logan.
child?
Yeah, hi, my name's now.
The other
Logan.
son. The good son.
A half-life is the time that it takes for 50% of whatever is left to disappear.
Yeah, exactly.
Yeah.
Lose its strength.
Good job, Tyler.
So, I mean, I learned it in the context of
5 years ago.
radioactive material, but.
Yeah. Same thing.
Well, the half-life for memory hasn't
The
gone away
half-life of
yet.
memory is greater than 5 years.
So in medication, it depends on what we're talking about, but in general, it takes 9 half-lives to 100% excrete a medication from your system. So, it can take quite some time, especially when you consider a half-life of 12 hours. You're looking at 4.5 days to get rid of that. So, now that said, like you were saying, so you start with 100%, and then it's 50, and then it's 25. So you quickly come down from the top, but it takes a long time to get 100% out. And it depends on what kind of dose you're talking about too. A normal dose, a few half-lives, you're not going to see any real effect. But if you have somebody that overdoses, you're already overwhelming those enzymes. You're potentially causing acute organ injury and slowing the process more. And so sometimes that really takes a long time to get those drugs out of their system.
So would then anesthesia be one that has a long half-life? Because don't they say you have like brain fog for quite some time
Yeah.
after you've been under anesthesia?
Yeah, the overall
I'm still
effect.
suffering from it. It's been like 6
That was
years.
12
it's fine.
years.
Yeah.
Yeah, I wouldn't say like, generally, like maybe like within the day, you should probably feel fine from that, I would expect. I'm not an anesthesiologist.
Dang it, so I can't use that as an excuse.
Yeah,
No, but we talked about it last night in that chapter, the last part.
Brain fog has something.
That shrinkage in the brain, thank you, Dale.
We were saying your brain was sloshing around. when you
It
were
was
exercising.
sloshing around. Don't work out.
That's a whole different problem there.
Yeah, we discussed that last night.
So the other thing about anesthesia though is they do have reversal agents too, just like they might use Narcan because sometimes opioids are involved. And there's other medications as well that will bind and reverse anesthesia. So, but usually they're not gonna like bring you like right back to normal. They're gonna get you out of that sedated state to where you're capable of going home. And so you may have fog, like you said, for a couple days, or I wouldn't say a couple days, a couple hours, maybe up to a day. But again, I'm not super familiar with the anesthesia side of things, so.
Maybe I'll ask Chris tomorrow.
Yeah, I'm speaking
Right,
a
isn't
little
that what he is,
offhand.
anesthesiologist?
Yes.
Yep, yeah, he's your guy.
Maybe he'll give me an excuse for brain fog. since
He
won't.
might.
I'll recommend you go binge drink.
Yeah.
That seems to counteract it.
All right, so, we've got therapeutic threshold, therapeutic index, and LD 50. So, all right, so I haven't used these terms in a while. Therapeutic threshold is gonna be like, what is the threshold you need to see the therapeutic effect of the medication? So there's like warfarin, for example, go back to that. They set a goal for somebody with AFib of an INR of 2 to 3. And so you're gonna get effect below 2, but that therapeutic threshold that we're looking for is an INR of 2 to make sure that that person is anticoagulated enough to not have an embolism. So that's kind of like, where do we need to get to at this medication level? Therapeutic index and LD 50, you guys, we're gonna have to help me with this one. I don't wanna tell you the wrong thing.
Well, I don't remember that part.
It's on page 564, left side, bottom corner.
How do you know this stuff?
I was just on it.
Oh, okay.
Oh, got it.
Which one are we looking at?
All right.
Sorry, we just lost the 2 people. I'll get him back.
Brennan never show up?
He's been working.
Good boy. I
We'll wait
texted
for a
him,
second.
you need to zoom in. I'm so bossy.
Do you guys need a break?
See, we'll listen to you, Jeff.
Take like 5 minutes while he
Sure.
gets them back online?
Sure.
I'm gonna go rinse out my cup so that it's not completely awful to wash later. It's not?
Dan, it's been pretty fast.
I knew Tyler Sweetie would need it.
Yeah, it was gross. Like garbage.
Pictures, you went to the
Yeah,
trash
one of the
can,
things we see is
took a
really
toss it
cautions.
before it went.
Yeah.
And then threw some peanut butter in, was like,
When
yeah,
you
this
have
is
to,
good.
Yeah.
12 more 5 minute break.
It wasn't even.
I think that's our other invite period. We're on a break right
So
now.
like, we're gonna say, oh no.
Yeah,
But by the time I'm on this, gosh, thank you again for coming down.
You actually have like real medication.
The free account checked us out.
This really does help.
Why?
Apparently Zoom started getting stingy a year into this pandemic.
Thanks, Zoom.
Google Meet's better. I like Google Meet.
So how much has it really become the most popular?
My son tranquilized wildlife. They have different
Okay.
species. It's kind of interesting.
Yeah, to go over, it looks like an hour at a time.
They use carfentanil, I guess, on they said nothing else touches them.
It's like mine.
You hit them with something else. It's very unique. But like,
Yeah,
carfentanil is way more powerful than
And,
fentanyl.
as soon as you're done doing whatever you want, you can cancel it.
I don't use it.
It'll cancel it.
Yeah, I don't think it's for human. Oh,
You can get it.
We can switch to Google Meet.
they have to carry
You do
a
that
pen
for
or an injector or something, and accidentally stick themselves.
Yeah.
Whatever you do.
How much time?
Yes.
Because we have Google Meet
For
for
seconds,
seconds.
so get themselves a person that work.
We can do hours and hours.
Extras?
So they always worry, you know, like, people say, well, why don't you tranquilize them down, and shoot a dart into this and kick darts into others? Yeah. Look, you know, with that drug in it.
At the zoo, if you,
Especially something like
Yeah, kids. Even at the BLM, it's nervous that somebody come across this.
Yeah, it's-
Must have read it.
if you do the monthly.
Yeah, I don't know, I mean, I know they don't read all that stuff, but it's extreme.
It's like onyx.
Then bears, they use something called Tilazol.
But it'll record the whole thing.
So if you bears, it's like, it's not your choice.
Yeah, that's all you only have to do one, but then you wanna do
But
it.
they also have reversal agents, once they get that reversal agent, it's minutes before that bear is back on the radar.
Not very happy.
Kinda like the guy that gets snarky.
Yeah, it's our
Really not
target.
wanted.
So that's what we should talk about too, is withdrawals.
Yeah, I mean, just going through the cardiac meds, everything else that we did would be really good too, I mean, just to kind of give us the, it's a good lesson for all of us. Did you find those drugs in the back of the chapter that were allowed?
I obviously didn't have to read the chapter.
Okay. Well, here,
I got to go through 20 minutes.
you know, most of it's pretty simple stuff, but it's all the stuff. Some of what we've had in the past, yeah, it's 570 on. Some of it we've had in the past. that
Again.
You don't have anymore type of
Me
thing.
first, no, I still want to go second.
And he was right.
But there's a variety of,
Because everybody at first was like,
I drink a lot of water every night.
and then the IV fluids, we typically just had the LR. But I know part of this is we would be able to have, and we used to have D50.
When we were practicing,
Goals of D50, but I noticed they mentioned the D10 and that may be in the next chapter too.
So D50 and D10.
All of the plastic as well.
Yeah.
we just shoved this whole thing right in.
Good.
So if there's anything we should know about that, probably be a good thing to know. But I think Chris will talk about the D50, I think, tomorrow.
Yeah.
normally he picked up faster than sometimes.
I was really bad. I took it right after work.
But yeah, I really appreciate it.
And I
It's
looked
been
at it and I said,
good. It's answered a lot of my questions.
This has been good.
Yeah, as I get older and I start hearing drug names and I realize that I've helped people that have all been taking different, because we always ask, well, what drugs are you taking? And they always reel off of
I'm like, I don't know what any of those are.
a litany of things, and I'm sitting there going, gee whiz, as I get older, will I have that same?
well, I'm gonna. Because I gotta go
I
out
do better
for-
with this kind of setup than reading. I need to hear it.
Yeah, me too.
So like reading all this last night, I'm like, this isn't.
I don't know how those kids do the online learning, to be honest with you.
I couldn't do it.
If I can't hear it and see it and have somebody to interact with.
Ask questions and, sorry if I'm asking too many.
Also, I
Yeah,
love
okay.
listening to them.
Huh? No, they can choose go longer, sorry. I'm that person.
Oh, yeah.
And I have seen people in the ER that, where they hit them with something and they just don't react. It's like, they're going, you know, we've given them like twice what their normal dosages, and they're just still sitting there going like, come on, lay something on me.
Yeah.
And me, I'm more like, give me a quarter dose, I'll probably be off singing in La La Land.
I tend to be, I talk a big story about all the partying that I do, but I'm super lightweight. And I don't drink anymore because my face can't handle it. I just don't metabolize it like I used to, I guess. I don't know, it just seems like I struggle with it, so it's just easier to say no.
I'm the same way. I think since I started doing this job,
Oh, for sure.
the big change, like now 30 years ago, but it was kind of like I'd see the tragedy involved with drugs.
Not worth it.
I can't say I ever had a drug problem, but
I'm hoping you'll see that. I'm working a bad record or something like that. Or just even seeing how people cheat when they have substance abuse. It's just hard on your body.
well, I think you get to see it firsthand at this
For
job.
sure. Like wearing seatbelts and making good choices.
Yep.
You see what happens when you don't. It kind of makes you think twice.
Ready to come back, guys?
Guys, you ready? Let's go ahead and kick her off here.
We're kicking people now?
Maybe, Tyler.
Just you.
You're closer to the floor.
I know, but I can hear.
You're standing.
Alright, so we're gonna jump back in with therapeutic index and LD50. The book's definition is the ratio, therapeutic index is the ratio of a drug's lethal dose for 50% of the population to its effective. Okay, so LD50 is lethal dose 50. Okay. These are just like brackets used for kind of describing the safety profile of a drug. Honestly, in pharmacy, I really never use these concepts too much. We have dosing guidelines and that's what we go by. We're not necessarily calculating the LD50 and saying, well, this only killed half the people. So it's not like that. So
You look lucky.
It looks like the therapeutic index is the difference, the ratio between what makes it effective for half of the population versus what will kill half of the population. So it's the
Yeah.
ratio between those two values.
yeah, that's a pretty good way to put it. A lot
How
of
far
times,
apart are those would be.
So basically that ratio between
One's
being enough to help
effective.
and being enough to kill you.
Yeah.
Let's not kill people.
yeah. So ED50 is effective dose for 50% of the population, and LD50 is lethal dose for 50% of the population. And then, like he was saying, the index is kind of that space in the middle, and that's kind of like, I mean, really, when this is really important is whenever they're developing drugs and bringing them to market. I mean, you need to know these ranges because then they need to set a dose that's safe in the middle, but yet effective too. It's finding that the dose that gives you the most benefit for the risk.
We wouldn't have to calculate, and that's good to hear.
Yeah.
Well, they have an example here of Narcan. Typically, the effective is what, 45 minutes? They were talking about takes
Half-life of naloxone is 45 minutes.
half-life naloxone is 45, typically 45.
But wouldn't we
minutes.
be talking about a dosage instead of a time though with this?
We would be, but I think it'd be handy to be aware it could be up to 45
25%
minutes.
to 90 minutes.
Yeah, so usually like in pharmacy, when I've seen this in school, it's been a chart. And so you'll just see a chart and it'll have dosages up the side. And then you'll have like brackets on that chart and it'll be lethal dose 50 at the top and effective dose 50 at the bottom. And they're just, usually what they want you to do is just identify that you understand what those concepts mean. So, and if you see it on it, they just use the chart as an illustration, but if you know the definitions of LD50 and ED50, then understand therapeutic index is the correlation of the two and like, you know, understanding the relationship, then I think you'll probably be okay on those concepts. They're not gonna ask you to calculate anything or anything more than, they may say like, they're just basically gonna probably ask you to define it more or less, if anything. Honestly, like I said, past the book, it's not anything people really use unless you're developing medications. So factors altering drug response. I feel like we've talked about this a lot, but we'll go through it again here. Age, sex, body or gender, body mass index. Those are all things like, as I talked about, like age, your kidneys, your liver become less effective. Women naturally just clear medications, like their kidneys just aren't as, I don't know why this is, but they just don't have the kidney output that men have. Whenever I calculate a woman's renal function compared to a man's renal function, I automatically deduct 15% off of theirs compared to the man with the same stats. So I really don't have an explanation for that, but gender does definitely affect things.
Would it be the mass of it, of the organ?
I mean, in theory, yeah. So with kidney function, I'm thinking about age, weight, your creatinine, which is a lab, and that's kind of it. You put those in an equation. But yeah, I mean, I think that's part of it. It's really just.
I think the kidneys are really bad.
Yeah.
That's
I mean,
interesting.
yeah, you're still 85%. Body mass index of some drugs will be retained, some are not. So like vitamins A, D, E, and K, you can actually overdose on. I don't know if you've ever heard of anybody like eating too much liver or anything like that, or too much vitamin A, but you can actually have toxicity from that.
A, D, E, and K?
Yeah. That's just my own little tidbit. I didn't see that in the book, so I don't know if you guys need to know that. It's interesting, yeah, because those are.
Saving that information for later, just in case.
Well,
it takes a while.
just, yeah.
Not gonna be giving Eric
Yeah,
like extra
I-
fee or something.
My dad suddenly declines in health after this. Or you.
Or Tyler.
Back hilarious soon, so.
Liver 3 times a day. No. Well, the thing about that is though, is like those vitamins are lipophilic as opposed to hydrophilic, and so hydrophilic would be like loving of water, or lipophilic is loving of fat, basically. And so whether it dissolves in one or the other. And so think about like, you know, if you're trying to wash grease with water, it doesn't work, right? And so you need soap because grease is lipophilic, basically, if you want to think about that. So your body mass index is, in essence, like, you know, it can change with your body composition. And so if you have more adipose tissue, then you have potentially more area to store those medications or absorb them away from your system. And so it can potentiate or decrease the effect of the medication, depending on what you're talking about. So genetic factors, there's really, at my level, not too much to say there, but just know that, like I said, some people are cats, some people are horses when it comes to medications, and that's about, short of doing a bunch of testing that we don't have the capabilities of doing here in Thermopolis, that's about all you can say about it. You just have to know to account for that sometimes. And that's why with medications, you get a starting dose and you have a max dose, and you usually will start somewhere low and titrate your way up to the effective response, because you're trying to account for that. You don't know what's going to work in every patient. Time of administration. The one time I really think about time of administration being critical with medications is with statins, which you guys probably won't deal much with too much, but your body produces cholesterol at night, and so some statins you take, which is like simvastatin, you guys are familiar, Lipitor, those kind of things. You want to take those before bed because they're most effective while your body's actually producing the cholesterol while you sleep. So if you ever have your doctor tell you to take those at night, that's why. Now there are some that you don't have to take at night, such as a atorvastatin. So it's not all of them, just depends on which one. Let's see, psychological factors. I mean, there is some credibility to placebo effect, and even just, you know, some medications take time, and sometimes things are helping you even though you can't feel it. So, I mean, believing is something too, I guess, even though you can't see it. But that's probably about all I can say to that, unless anybody saw anything more on that in the book that they'd like to share. Okay. Let's see. No. You guys are familiar with anaphylaxis, right?
Yep.
Okay, good. Talk about delayed reactions. I just want to make sure we don't miss anything here. I think we're pretty good on that. I'm gonna jump back to section 1 in the beginning now. We're gonna do a little bit of legislation. Do you guys wanna go over that, or you guys, it's kind of definitions. And honestly, I don't know them off the top of my head, because again, it's another thing I don't use in practice, so. I'll probably just encourage you guys to look those up on your own.
How much of that stuff's gonna be a test?
I have no idea, Amy. I can't imagine there's gonna be a lot of it. I think there's so much that they can ask that. And most of it we kind of understand anyway. I mean, I don't see.
Here, I'll give you guys the brief rundown of what I remember. So, the Pure Food and Drug Act is an FDA act that basically is just ensuring the integrity of your food and your medications. And I think that stems from, there was a book written in the early 1900s about a Chicago meat factory, and I don't remember what it's titled.
Upton Sinclair, it was, how can I not remember what it is? I do.
Jungle or?
Is that
Jungle.
Jungle? Yeah, that's what I was
Yeah,
kind of
that was
thinking
it.
too. Okay, so basically, he wrote this book about how disgusting basically the processes were, and so they caught the attention of the media and the FDA, and they implemented this drug act that just says, you know, we need to have integrity, things need to be clean, they need to be safe for consumption. So really good thing for us. Federal Food, Drug, and Cosmetic Act, that one I don't know off the top of my head, along with Harrison Narcotic Act. The Controlled Substance Act overall is basically just setting aside a subset of medications as controls. It's giving control levels to medications. Does anybody know what control levels there are in medicine?
They're schedules.
Yep, they're schedules. Yep, that's another way to refer to it. Those
1
terms are synonymous. So
1 through
control.
5.
Good, yeah. So you guys are on the right track. There's 1 through 6 and then OTC. So, and I think this handout goes back over this again. Schedule 1 or control level 1, again, those are synonymous, are illicit substances. Those are heroin, marijuana right now in Wyoming. LSD, yeah, so anything like that.
Those tend to be
Meth.
addictive substances.
Yeah, so what the definition is they're addictive, they have addictive properties, but they have no medical indication, okay? And so then you get to 2 through 5, and these are, in pharmacy, these are the medications I have to control and keep really close track of, but they can be used. And those are basically, the control level 2 is their own little subset. They have very, very high addictive potential, but they still have medical benefit. So that's your morphine, your Morco, Vicodin, any of
Fentanyl, Ritalin.
Percocet.
Ritalin was
yeah.
one that surprised me. It was a Schedule 2.
Yeah, I thought so too.
Yeah, because for somebody who doesn't have like ADHD, it can be, I've heard that it's the equivalent of like speed for that person. So,
There's a whole like show on Netflix about that their colleges and stuff are using it as nothing but speed.
yeah.
Addie. That's the name of the Netflix.
Oh, I was curious. I heard that.
Yeah, it's, so,
Yeah, it's like people.
and then 3 through 5, I would say they still have quite a bit of medical benefit, not as addictive, but still potentially abusable. Schedule 6, also referred to as legend drugs. Those are your medications that you can't get over the counter, but they don't need to necessarily be like behind a locked vault. That'd be like your blood pressure medications, your cholesterol medications, those things, the normal stuff that your doctor prescribes. And then you have your OTCs, which we can buy over the counter, of
I
course.
think oxygen, you have to have a prescription for oxygen.
Really? Yeah.
Over 21%.
And actually, a lot of times too, the prescription requirement is coming from insurance as well, because otherwise it helps the insurance pay if the doctor's saying you need this too. So there's times where doctors will prescribe over-the-counter medications just because that's what it takes for insurance to pay for it. So sometimes that's a driving factor. All right, Drug Enforcement Agency, that's the DEA. Those are the guys that keep close tabs on those controlled substances that we just talked about, and the illicit ones. What's a narcotic?
Well, I would have said the schedules.
I don't know.
Type.
Those are,
Yeah.
those
But,
schedule ones.
but you
Yeah.
hear them as schedule 1 type narcotics, I guess.
Yeah, so a narcotic is basically an illicit substance, so Schedule 1s are all narcotics. And I suppose you could probably classify even the Schedule 2 through 5 as narcotics if they're in the hands of the wrong people, but traditionally it's Schedule 1s. They're the illicit, illegal drugs with no medical indication. Yeah. Yeah, so like when you, if you have a prescription for Norco, that's not a narcotic, that's the medication. So that's the difference. Now if you're taking heroin, that's a narcotic. So that's kind of the difference there.
They just changed the name.
That's good for that.
So, with Hannah, I have so I take, well, I don't even know what the name is, too many. It's like a combination of Barbidol and
Yeah.
Tylenol, you know.
I know what you're talking about. I don't carry
So,
no formulary. I haven't seen it in a while.
So I take that, and when we were talking to, I don't remember if it was talking to Hallie or talking to her, the doctor down in Denver, but she said that she couldn't, cause I told her, I said, well, it worked really well for me, is that something that would be, you know, acceptable? Maybe we could try it for her to see if that would, you know, and she said that she can't prescribe it to her cause it's a narcotic. So.
I asked that question because people frequently use that term incorrectly. And so did you say you saw an NP? Did I catch that or did I?
Well.
Was it a physician, an MD or a PA or NP or, you know?
She's got like 4,000 letters behind her.
Yeah,
It's
that's
our
okay.
Headache doctor in Denver at Children's.
So.
And I can't remember if it was either her or Hallie over here that said they couldn't.
So I presume that narcotics, the word was used inappropriately in that situation, and that's why I brought that up, because I see it all the time. The thing is, some states have laws on what level of medication certain prescribers can prescribe for, and maybe even age restrictions, and I'm not familiar with Colorado laws. That could have been part of what you run into. I know Illinois has those restrictions. Aside from that, I'm not really sure.
Yeah, I know it had to do because she's under 18.
Yeah,
So
and
it's an age restriction and like I said, I don't remember if it was down there or up here, but.
Right.
So Dan, are you saying like a PA might be allowed by law to issue scripts for a certain level, but not as much as an MD?
Yeah.
Am I understanding you right?
So, yeah, right. And I don't remember because I'm not actually licensed in Illinois, and it's been a long time since I was there, but I think NPs, nurse practitioners, and physician's assistants are maybe, I want to say they can prescribe level 3 through 5, but they can't prescribe C2s maybe, or something similar to that. There's some restrictions on their licenses with their prescribing.
That's something different in their scope of practice.
It's state law is what it actually is, and here we don't have that restriction.
My daughter-in-law is a nurse practitioner, and her sister's a PA, and I know there's even differences between PAs and NPs.
Yeah.
What they can prescribe. NPs have a little more leniency than PAs.
And then, I mean, honestly, if we, on that topic, even physicians can have restrictions on what they can prescribe. So, like methadone for opioid dependence, for helping people off withdrawals, or Suboxone for opioid recovery as well. You have to have a special DEA number and that special DEA number means you have a special designation to prescribe those medications. So not even every doctor can prescribe those. So, yeah, there are a lot of little nuances here and there. That's kind of the best one. That one is one I do deal with in Wyoming, but there's everywhere you go it could be a little different too. Development of pharmaceuticals. So the FDA approval process, this was in the book I saw. Does anybody remember it? There's 4 steps. What's step 1?
It's test in healthy volunteers.
Is that 1?
Phase 1 says the new drug is tested in healthy volunteers to compare human data to those in animals to determine safe doses of drugs.
Okay.
First step is animal studies, so I think.
Oh, gotcha. This
Yeah.
is the clinical trial that I'm looking at.
What page is that on there?
547.
Follow along, guys. Yeah, so generally, I'm thinking about phase 1 is animal studies. Very few people are involved. phase 2, you're gonna get small populations of people. I think the book here says about 350 to 300. And again, so phase 1 with the animals, you're really establishing a safe dose, that LD50, that ED50, that's what you're looking for there. And then you're getting into the phase 2. At that point, you've already set a dose. You've already established that this dose isn't gonna kill anybody. Like, it's reasonably safe. Now we're looking at a safety profile. Are we seeing any toxicities? Are we seeing adverse reactions that we didn't anticipate? Things like that. Once you said, okay, this is safe in people, like we're not hurting people, then you go on to phase 3 trials, which is where when you, like in the COVID vaccines, maybe you guys have heard on the news that it was tested in 30 and 40,000 people. That was a phase 3 trial where they were looking for large population safety profile. They want to see, you know, the incidence of headache is 6.2% in this vaccine. And within a population of 300, your sample size isn't large enough to make those conclusions, but with, you know, 30 or 40,000 people, you can make those conclusions. But even then, it's still hard to apply those numbers to the general population because there's millions and millions of us, right? So then, after phase 3 though, you can get an approval, and then after that approval goes out, you can do phase 4 trials, but you still do phase 4 trials, and that's what they're doing now with COVID, the COVID vaccine, where people are still reporting their adverse effects, and they're still tallying data in the broad population.
How do they decide who to survey? I mean, I would be surprised why they wouldn't ask anybody who's taken it to fill out a quick survey.
They
Because
do.
you think
They
about
do.
Mark's
You put
reactions
it on
compared
your-
to mine.
You put it on your phone and
Yeah, you just
they
scan
ask
it,
you
your
every
QR code.
day what you're doing, so both shots like every day, and then it goes on for like 2 or 3 weeks.
I got it the first time I went in, Amy.
Yeah.
They had a
Maybe a
QR
paper
code
and
up there.
like
to
Oh,
scan
maybe
your-
so.
Well, I didn't have
I didn't do it.
I don't remember having any kind of paper with a QR code.
Yeah, it was on the first paper we got.
In my experience, this is the first time I've ever seen that. I would assume in the past that they were still just setting up like more manually organized trials where they were selecting. Well, a lot of times if you go to clinicaltrials.gov, you can find clinical trials and you can even enroll in trials if you want to be a participant.
Oh.
And so they recruit people, they'll call people, probably once you do it once, then they're gonna start calling you, hey, you wanna do this?
Yeah.
They do it
So,
How do you feel about this shot? But,
Depends on what shot they offer, I guess.
But yeah, they gather a population of volunteers and then, and sometimes they're paid volunteers too. And then,
Tyler.
Now you're talking.
Yeah, you look at pay for college.
That's not beer money, okay?
Why not?
Adverse effects to the medication.
So we already talked about drug forms, kind of. The only thing we didn't mention was gases, and honestly, we hardly ever use medications as a gas. The only thing I can think of is sevoflurane. In the OR, we use it as anesthesia, but that shouldn't be anything that you guys are seeing in the field. I guess maybe if you want to consider like albuterol through a nebulizer a gas, but like.
I think the new one that I saw when I read through the AEMT stuff is nitrous oxide.
Nitrous oxide was what was in the book, yeah.
Some places are being allowed to use that, I thought that was interesting.
Yeah, I thought
I don't
that
wanna
was.
use
Cool.
I think.
We get a tank on the
That's
end.
as good.
Yeah.
Well, we're gonna have
Yes.
to, we're gonna have to know about it because it'll probably be on the test, the nitrous
Yeah, that's
On your way back to
oxide.
that transfer.
You are prepared
Well,
that
I was just thinking
may
making
not.
house calls for gas shots.
What, curiosity, when you go back to those phases, or those stages,
Yeah.
the schedules, where would,
Schedules.
the schedules, where would Dilaudid, it's a 2?
Yep.
Cause it has a medical use.
Right, Dilaudid's hydromorphone, it's an opioid. Pretty much all plain opioids are Schedule 2. So if you see anything that you can, that's hydromorphone, fentanyl, oxycodone, hydrocodone, morphine, plain codeine, which you will probably never see. Those are all C2, so anything plain opioid. And then if you guys recall, like when you start seeing, and just keep in mind, like oxycodone, hydrocodone are always C2s, but codeine in particular can start dropping to a C3 and to a C5 in combination with other medications. And that's because they deem the ratio as not abusable. So like in Tylenol number 3, it's 300 milligrams of acetaminophen, 30 milligrams of codeine. It's a Schedule 3. And that's because you would overdose on Tylenol before you could abuse the codeine.
Oh, okay.
So you see stuff like that. A lot of things like atropine diphenoxylate, which is for like bad diarrhea basically. It's a Schedule 3 or 4, and I'm sorry, I don't know the answer to that off the top of my head, but the atropine is an anticholinergic, and so you would get very unpleasant effects from that before you could abuse the other medication. And so that's kind of where, like, you see Suboxone. Are you guys familiar with Suboxone? You ever deal with that? You guys would probably, there's a good chance you'll come across that at some point in your career, because it's frequently given to people that abuse opioids to help them come off of opioids. And so Suboxone is a medication. It's naloxone in combination with buprenorphine, which has opioid-like effects. But the naloxone, right, is an opioid reversal agent. And so people chronically on opioids who abuse them, they develop a tolerance, but they also develop a dependence. And so if you just try to stop them, it won't go well at all. And likewise with giving any sort of reversal too fast, you can bring them into withdrawals, and that can drive them right back to it. So one of the medications we can use is Suboxone, which is this combination drug, so they can get the benefit from the buprenorphine, but the naloxone is antagonizing the effect at the same time. So we're given this drug with its reversal agent in the same medication, and it stops you from abusing it. It greatly decreases the abuse potential. So, so when you see those combinations, I guess my point being that you can start decreasing the control level because they're much harder to abuse. But generally, if you know what your opioids are, they're probably a C2. One other thing we should probably talk about on that topic, though, while we're there, is benzodiazepines. Are you guys familiar with benzos? People say that a lot, right? Can anybody name any? Okay, so that's all right. Alprazolam, also known as Xanax, right? Lorazepam, which is Ativan, diazepam, which is Valium, midazolam, which is Versed. Okay, commonly abused, I would say, right? So benzos are depressants. I'd say the #1 adverse effect, similar to opioids, is respiratory suppression. Okay, so used in combination with opioids is whenever you see a lot of problems with that. But they are commonly abused, and they all end in PAM. If you guys noticed that similarity for the generics, and those are Schedule 4s. I saw a question in this book, in this chapter, about that. So I would know your opioids are 2s, and your PAMs, which are benzodiazepines, are 4s. Those are the 2 big, broad drug classes that are commonly abused that, if you're gonna know anything, those are the 2 that I would know. Good to know. All right, so now we're gonna get into naming, which is kind of, so a lot of times, it talks about chemical naming here. Have you guys ever noticed that, like, let's see, like morphine is called morphine sulfate, or levothyroxine is levothyroxine sodium? Like, there's always a salt formulation afterwards, and really, unless you're getting down into the real nitty-gritty of it, it's not really necessary to know much about that, other than, like, I just wouldn't get distracted by it usually. Just know that there's a salt formulation, and really that's everything we're dealing with at the end of the day is a chemical substance. And so it's a compound. It's all those elements you see off the periodic table in some combination. And when you get into medicine, if you want to break down the micro, what's the word I'm looking for? Like the chemistry of these medications, you can draw them out. Just like, I don't know if anybody in here took like organic chemistry when you had to draw the compounds and it had like all the shapes and whatnot. So every medication has those drawings. You can draw it out if you want to. It's crazy complex. And
so it's molecular.
Molecular chemistry, that's the word I was looking for, yeah.
Biochem or?
Yeah, so then when you combine that with the biochem, that's when you get the effects in the body. My point being that just keep in mind these are all like different molecules. And so that's all, like, usually you have to combine it with some sort of salt or whatnot, because if you don't, it's unstable. You start seeing those negative and positive charges, and it just wants to bind to anything, and sometimes that salt is important for absorption or making it stable to get to where you want it to go for its effect. So it's really all you need to know about that. Don't let it distract you. Just expect to see weird salt compound names, whether it be sodium or, you know, whatever it could be, sulfate. There's just always that, but don't let it bother you.
So when we're writing down like the med list for the ER,
Don't worry about
We
that.
don't have to include those necessarily, or are they gonna get enough information without it?
Yeah, usually you get enough information without it. There's like, I can only think of one instance in all of medicine where it makes any difference, and even then it's pretty minor. So, yeah.
I always wonder about that. It's like, I could spend the next 45 minutes writing down all of these
Yeah,
things, cause some of them get pretty long.
just keep in mind though, like sometimes don't mistake that for like a combination. Okay, so like I talked about Lamodal, which is atropine diphenoxylate. Those are two very different medications in the same form. Okay, so but whenever I talk about like levothyroxine sodium, that sodium is just the salt content for the levothyroxine. So just don't get confused by that, but don't get distracted by the salt name.
Okay.
And yeah, the providers won't care about that. So, let's see. So, generic versus proprietary trade names. Are we all familiar? We see that at the grocery store, right? You get the Walmart value brand, or you get the Regu. You know, it's the same thing. When a medication's made, that manufacturer gets proprietary rights to that medication for production for some amount of time. I think maybe like 7 to 10 years. I'm speaking offhand on that, so don't quote me. And that's because it takes a lot of money to produce medication. So if you don't give them that exclusivity, then they're not going to do it because it's not financially feasible. But then afterwards, then once those rights are up, then you can start producing generic medications. Drug prices come down. It's good for the general population. So everybody kind of wins with that format.
We see that mostly when we're filling out the paperwork. Sometimes you'll have a medication on your list that the patient gave you the name, but you go to type it in and it's nowhere on the list because you don't recognize whether you have the generic name or
Yeah.
sometimes that pains me up a little bit.
Generally, for most medications, if you would really need to, Google's pretty good. You can type in what you have into Google and type brand name or generic name after it, and it'll come up. And I can't say that I've ever seen it being inaccurate. So just something to keep in mind. We all have smartphones now, pretty much. That's really, really handy. So let's talk about some concepts that are related to generic and brand names. So when it comes to medicine and you see, like let's use Dilaudid as an example. So Dilaudid is the brand name and hydromorphone is the generic ingredient, okay? And so hydromorphone is not Dilaudid necessarily, right? But Dilaudid is always hydromorphone. Does that make sense? Because the hydromorphone could be made by the Dilaudid company, but it could also be made by any number of generic companies that produce hydromorphone. And so you'll get into like some legal issues with that where you guys will never have to worry about this, but with packaging and rebranding, it's inappropriate to buy a medication that is just a random generic hydromorphone and label that medication as Dilaudid. It's misbranding is what they call it, and it's actually against the law. So
when you have Dilaudid, you know a specific company made it.
When you have Dilaudid, you have the brand name. Yep. Yeah. Now in medicine, I don't stock Dilaudid, but it's no issue for me to say, when I'm talking to Dr. Bomagen in the ER, like, hey, this patient's on Dilaudid. I'm not concerned about whether they're taking brand name or generic. Dr. Bomagen knows what I'm talking about.
He knows the effect.
Yeah. So that's a good thing to understand, but it's not super critical for what you guys will be doing. But I think it does mention that in here. Authoritative sources of drug information. These are kind of going by the wayside in modern medicine because we have databases and we have smartphones and it takes way more time to use this stuff. But USP is the United States Pharmacopoeia. The only time I refer to that these days is for sterile compounding. Physician's desk reference, drug package inserts. We can talk about that one. And drug handbooks. I mean, it probably talks a little bit more about these in the book and it might be worth being familiar with them, but overall they're regulation references and they're drug references for medications. Like I said, we're not using them these days. We're using UpToDate and LexiComp and these databases that are right at our fingertips. The one thing I will talk about is package inserts. Those are pretty handy. I don't know that you guys will see a ton of them in the field because pharmacies have repackaged your patient's medications for the most part. But
Or that's the first thing the patient throws behind.
yeah, that too. No one wants to read them. It is good to keep in mind if you ever get a chance to look at a package insert because they're always in the same format. So if there's something you want to know about a medication and you can get the package insert, like once you're familiar with them, you always know I need section 2, I need section 6 for this information. Most of what you guys would probably be looking at is probably in section 1, if you guys would even need it, but something to be familiar with. They are standardized format. And once you get them unfolded all the way,
Without
and bring your readers,
Right.
but other than that.
A lot of fine print.
Yeah, so, again, I mean.
So, now we're talking about different drugs. Is there, oh man, crap, if there's that many, let's say we could put something up on the wall in the ambulance, but if there's.
I would think it'd be
In this
easier to
chapter,
use your
Mark,
smart
there's
phone.
several
Try to
pages of
find
the
what you need on
ones
them.
that an A would be allowed.
We have.
If we had something like that,
Cable.
you know, a shorter version of those 4, 5, 6 pages.
At least of the
That would be
new ones.
handy.
Like, obviously, we know how to administer oxygen. We're probably pretty good on,
Oral
epinephrine.
glucose.
But like, glucagon and, like, the newer ones, that would be super handy to have, at least until we get more comfortable.
Right.
So, and actually, most of those you can even pull offline too. If you Google, I've usually been able to find the package inserts I want on Google, and then just open them up as a PDF. I can help you guys with that if you wanna just swing by.
Yeah, that'd be an easy way to do it.
Yeah, the only thing is if we were in where we didn't have access to our phone service, like sometimes in the canyon, you don't, I guess you just wait till you get out of the canyon, right,
Yeah.
right.
Well, and if you guys are, I mean, for the package insert, I don't know that it's necessarily something I would carry around all the time, just cause there's so much excess information, but if you're worried about, it sounds like maybe administration is what you're most concerned about.
Yeah.
That might be worth, using the package insert as a reference, but then creating like a cheat sheet or a guide, a
Mhm.
1-page like protocol, basically, this is how you do it.
Well, they kinda almost have it, like even
It's-
just having this information.
Yeah, just that
From the
little bit
table,
that's
don't
in
you
there.
think it-
I thought that was pretty, to the point, kind of the
Yeah,
bullet, so to
I liked
speak,
that.
570 on.
Yeah.
Each of those has a
Yeah.
quick section.
Yeah, and if somebody wanted to make like you could probably fit almost all that on cause that dosage and administration section, you could label with the drug, and then you could probably put that on one or 2 sheets and have that laminated.
If it's not on the wall, even just have a quick, a little
sure
book,
someone's
and we
outlined
can flip through, have them
out
in a
every
binder,
case.
and then we could just flip through and find the one we need.
I'm sure there's someone, online, I'm sure there's someone that's got all the EMTA medications on a form.
Yeah.
Yeah, I'm gonna guess it.
Find one.
I just,
Sure.
any kind of extra help I could have would be super nice,
Yeah.
cause I won't remember this stuff off the top of my head.
Yeah, just download it to your phone and just have it there. Of course, if you're like me, I forget my damn phone.
Yeah, or my glasses.
Yeah.
We did that.
Well,
not long ago.
there's a
I know, I've
cross-check
used them, thank you.
that it tells us to use that I think would be good for us to know.
That's on what page, Tyler?
568.
Oh, that from, Kansas? Yeah, I was looking at that.
Yeah, I mean, especially when we're first starting out with this after we get certified, like, this isn't just oxygen now, this is other stuff, so.
Just making sure that we're double checking
doing
each
things
other.
right. Yeah.
That's really good practice. I mean, even myself as a pharmacist, like, I never look at anything once. Like, always gotta look at it, every detail twice. And you really have to practice to, like, ingraining that in your mind that you need to check every detail. Because you'll not realize it, you'll get busy, and you'll look at it and you're like, yep, that looks right. And you'll realize that you didn't consciously, like, think about those details, and it's amazing, it'll be wrong and right in front of your face, and you'll say, yep, that's good. And so if you don't, like, practice and, like, hold yourself accountable, something will get by you eventually if you're not careful.
Well, we had an incident with Dad where there were 4 or 5 people who saw the same box, and it was a way overdose situation, but yet nobody was catching it, it's the same kind of thing.
Yeah,
I may have had a little too much Dilaudid once, did not like it.
This was morphine, so
It was awful.
I did a good job with him. I really
Eric
overdosed.
left me in the hospital because I wasn't any fun to be
Yeah.
around.
And then I told him from then on out, I was like, I don't
Not
want
doing
to
the
take
law.
your
When I had, MRSA,
Uh-huh.
the nurse gave me my full dose too soon or too quickly. I don't know what happened, but I know that I was climbing off the walls. It was awful. It's like, do not give me that again. I'd rather deal with the pain. It was
Well,
awful.
see, we had this situation with morphine, and we finally figured out Dad was highly sensitive to it too. And like, so like I gave him a nighttime dose, which turned out to be like 3 or 4 times what he was supposed to have. And the next morning he's falling on his head trying to put his underwear on. And it's like, what the heck?
Yeah, that's
And it
awful.
took like 6 or 7 people to like, oh.
Yeah. So, those are great examples. I mean, you really do have to be very, very careful. There's a lot of details involved. We'll hit on adulteration really quick. This is similar to misbranding like we talked about. Anything you do that, compromises the state of that medication. So you can have adulterated medications, like you need to be like improper storage, improper labeling, expired medications, those are all factors. And so for room temperature medications, typically you want to store those between 67 and 76 degrees. I remember that range because they're inverses of each other, right? 7.6 and 6.7.
Oh, there you
It's
go.
a 9-degree range. It's pretty easy.
Trick.
Refrigeration is the same way, if you remember that concept. It's 46 to 37. So it's still the 7.6 concept, but 4 and 3 doesn't work as well. And that, I mean, there's probably nothing wrong with a little bit colder than that, but just a lot of refrigerated medications, you don't want them to freeze. So a frozen medication that's not supposed to be frozen that you thaw out and use could be considered adulterated. A medication that's been possibly in a hot ambulance at 110 degrees in a Wyoming summer, that could be adulterated. So you want to be careful with that stuff because it can, a lot of times what it does is, again, we're talking about these molecular chemical compounds, right? And so that heat can deteriorate those products and denature proteins. And so it's hard to say that there would be any harm that would come from that, but it's very logical to think that the medication may be less effective. Which, I mean, in the case of, Narcan, like, that's important that medication works. So you
What
gotta
about epinephrine, EpiPens? I mean, is there a point where,
Turn yellow.
is it
Yeah.
the color? I had a neighbor kid who had allergies, and mom gave me an old EpiPen and said, is there a point where you just you get rid of it?
That's really, it could be a tough situation. So
Yeah.
epinephrine should be protected from light, and that will be the number one reason why it changes color. That said, I've had medication that I've kept in a box sealed, and still I've seen it discolor. And so, in my opinion, when that happens, I throw it away. I don't even risk it. Now, whether it's good or not, I have no idea, but I know there's something not right about it, and so I get rid of it.
It's not worth it.
Now, like with an epinephrine pen, I mean, keep an eye on them, check them. You should be doing monthly outdates anyways to make sure your medications don't expire. And it's good to like check that color to make sure you don't see anything changing.
IV fluids even, Amy, and
Yeah.
we go through and we check the date.
And IV fluids, I mean, you can get a nick in a bag and that thing will leak out real slow and you won't even realize it. And then next thing you know, you're like, oh, I got an empty bag, this is useless. But
How about freezing on IV fluids and other things? Because that's something here in Wyoming, we probably see more of the, typically winter 10 below than we do the
yeah.
110
Too hot
in the
stuff,
summer.
right?
So
Because in the ambulance barn, the ambulance stays fairly cool.
Unless it's parked somewhere for a time period it's not running.
do your IV fluids freeze?
No, not in shipping, that's only if they were freeze.
Yeah, I wouldn't, well, in theory, there's enough
There's a
salt in
fact
them
that
that
they
they just
don't
won't
use.
freeze.
They shouldn't freeze.
But they could, I mean, if it gets cold enough, anything's possible. I mean, it gets darn cold here, so. It's probably, IV fluids in particular are just salts, and so they should theoretically freeze. Now,
I had a bag of LR freeze in
You
my
did?
pack that I left in my pickup. It was
Yeah.
outside and minus
I would
10 or
certainly,
20.
I don't
Yeah.
know. I mean, short of calling the manufacturer and seeing if they have any data, I really can't give you guys a scientifically founded answer on that. I know, I can tell you the recommendation, and that's to keep it between 67 and 76 degrees. I also know how practical that is. So use your best judgment, I guess, is my advice on that. I mean, IV fluid, I feel a little bit more comfortable with than, say like epinephrine or those medications. Those are a little more sensitive because they do have like more complex chemical properties. They're not just a simple salt. And back to your epinephrine pen situation. As a professional, I mean, the law is gonna, I don't know if I would even say the law, but if you ask any like official resource, they're gonna say like, if it's expired, if it's discolored, don't use it, right? But you also have to keep in mind that like, if I had somebody, and this is my personal opinion, offhand, unprofessional aside, if I have somebody dying in front of me from an anaphylactic reaction and I have epinephrine pen and it expired 6 months ago, like, do you let that person die or do you use the epinephrine pen? And that's a really, really tough place to be in, you know.
You take on a lot of liability.
A lot of liability, yes. So, I mean, my best advice is keep yourself out of that situation by doing monthly outdates.
Right.
It's
Get
very
rid of it.
simple, and it's a much bigger deal when you're at that point. And then you avoid the question altogether.
Okay.
But that becomes a moral situation that you don't want to be in.
Better to not have it than if you.
Yeah.
Than to
If you can avoid
have
it,
that
do that.
dilemma. Yep. that's
Fix
a
it
good
on the
point.
front end, right?
Yeah, if it's Tyler.
Yeah.
Well,
It depends. How was he the day before?
hey, I've never gone into anaphylaxis.
A bit of advice
Probably.
on adulteration is that the only people that can relabel and repackage medication are pharmacists, okay? So, you should never be unit dosing or repackaging, anything like that.
I think we're safe there.
IV medications, once they're punched, any sort of puncture or access to that medication outside of a sterile environment, it needs to be started immediately, like within 1 hour. And then, aside from that, I wouldn't use it again. So if like, I don't know, are you guys, I mean, maybe Narcan, you guys are using vials of that, nitroglycerin. So like, if I punch a vial of nitroglycerin and I was like, oh, maybe we're not gonna use it on this patient, I sit it aside, and 3 hours later I need nitroglycerin again, that's trash. That's how I would consider that, okay? Now, nitroglycerin, I punch it, I start it on my patient within an hour, and it's 2 hours later, it's still generally okay according to the US Pharmacopoeia. But that's just because of the sterility, right? Intravenous has to be sterile. And so those medications don't have preservatives in them. And so anytime you access that, you've introduced particles and you've introduced bacteria, especially if you guys are outside. There's tons of bacteria and there's tons of dirt in the air all the time when you're outside. And so doing that is, starting as soon as okay because that bacteria hasn't had time to reproduce, but when you let it sit after that exposure, then there's nothing stopping that bacteria from replicating. Good question.
So, well, it just, I mean, you might not know, but what's the purpose of having like multiple doses in a vial then? Like, so, the other day I was helping with a lifeline and they were given something, I can't remember what it was. But it was like a 4-dose deal with that. You know, and I think she gave him, at that point, I think they were giving like 2 doses, but,
Yeah.
what would be the point if it's that sensitive? Why do they even package it that way then?
I would first be really curious to know what the drug was. That would help me a lot. There are multi-dose vials that do have preservatives. I don't think, off the medications I've heard from you guys don't have any. If you would come across those, you can access those, and then they're good for 28 days after first accessed.
So, atropine, maybe?
Atropine?
It was to like settle them down so that they would stop, like, cause they were, the patient was just not combative, but kinda getting to the point of combativeness, and they had to get in the helicopter. And so they gave them that to settle them down so that, you know, so that they didn't have to do the rock or whatever.
Okay. It could have been a benzo, maybe like Ativan, maybe?
Ativan, that's the word.
Okay.
I knew it was an A word.
Yeah.
Atropine and Ativan, big difference there.
Yeah, but a great example of a look-alike, sound-alike that, remind me, I have a story for you guys here, I'll write it down, that's very similar to that situation. Okay, so the question being like, why would it have 4 doses on board? And so like, I'm not sure what they stocked. Was it a big vial or like a little bitty guy?
It was probably about that size.
Okay. So hard to say. They make a 10 milligram vial and they make a 2 milligram vial. And so they usually will try to package, and they're single dose vials, as close to the administration amount as possible for that reason. But if the person was giving a little small, like 0.5 milligram dose, which isn't unreasonable at all, then it's reasonable to think that they would have, you know, not used the whole vial and had some to reuse. Now, as far as like what I would do in that situation, if it's the same patient, I'd be willing to draw up and use it, and then 15 minutes later, maybe a little more, 30 minutes later. But like I said, if we're getting past that 1 hour mark and we're getting into that 2 and 3 hour mark, then I think it's just safer to use a new vial. It's not that expensive, and the repercussions of something happening are much worse in my mind.
Well, and that could be why they pack that. I mean, if it's a 45 to an hour minute flight, then,
Yeah.
you know.
Yeah, and so like during that hour, like that's fine. Now make sure also, on this topic, you don't want to be using the same medication on multiple patients. Like that vial, if they've got by chance 2 patients in there, it'd be inappropriate to use it on this patient and then use it on this patient because of cross-contamination reasons. So I don't know that you guys run into that much or no?
No.
Okay.
We're not giving Moderna vaccine.
Okay, yeah. So everything we've just talked about is a huge problem with the Moderna vaccine, right? Because they come in 10-dose, multi-dose vials, preservative-free, and they tell everybody you have a 6-hour window to give these vials, right? Except for the fact that outside of the hospital, people are drawing them up in an asterile environment. And so I've been collaborating with our public health to tell them, like, guys, keep in mind, like, although they tell you have 6 hours, USP says you don't. So just it causes a lot of challenges even for us in medicine, in the hospital too. Were you gonna say something, Jim?
No.
Oh. So the story I was gonna share with you guys on the lookalike sound alike is there's a nurse at Vanderbilt University in Nashville, Tennessee hospital, and they had, you guys ever heard of vacuronium? It's a paralytic that they use for anesthesia, and then very similar to Versed, right? And so in the hospital, we use the Omni cells, if you guys have seen those when you're in there. And so a lot of times you pull your patient up, and if in the ER, or if they don't have med orders, you can just search the medications that are in there. So VER, Versed vacuronium, I guess it's probably VE because vacuronium has an R later. But anyways, the VEC would come up before VER. So this patient was going in for like a CT, I think. Very, very nervous about claustrophobia and whatnot. So nurse goes into the Omnicells, puts VE, hits the first thing she takes out, draws it up, gives this patient vacuronium, paralyzes her consciously, so she's not sedated. So she's already scared, and instead of getting a benzo to calm her, she gets a paralytic, and she goes into the CT, nobody checks on her, and she suffocates consciously and dies.
Oh my goodness.
Oh.
It's that simple. So like, and that's like something every day, like pull up Versed, give a little bit. I bet that nurse did that every day. But it's that simple to like make that mistake. So, and it can be that costly when you're wrong. So you just have to really, really watch what you're doing. And when you think you've checked enough, like just check again, you know, whether it be your rate, if it's nitroglycerin, or, you know, most things are pretty, that you guys are dealing with aren't too bad.
I had a case one time I worked on where it was a decimal point was the issue.
Yeah,
And so somebody got like 0.2 instead of 0.02.
Yeah.
And that, you know, it was a really sad case because it caused a death. I can't even remember what medication it was. It's too many years ago, but
Yeah.
that decimal point was the issue in the case.
Yeah, it's crazy. And like, no one goes to work and wants to make a math mistake, right? Like, and it's just unfortunate that there's that much responsibility whenever you're dealing with these medications, but they do carry a lot of weight, so just be extra careful. And obviously, like, if you guys have another resource, you're like, hey, can you double check this? I think that's great practice. It's wonderful practice. Yeah, let's take 5 minutes, give you guys a little break, and then we'll get into medication classes.
I can't believe they don't have some kind of IV warmer that
Been really interesting.
we could put in, because I still think about when we have a patient who's already hypothermic and we're giving them cold fluids that's a problem.
Yeah,
I know, Tyler, but you haven't got me one in my hands yet.
Well, my professor never gave us back that.
Did what you create work? It did? How did you power it? How did you produce the heat?
It was a battery-powered rechargeable cell. So warmer for period cramps that we bought off of the internet and then attached into the bag with insulation.
So what if you had a bag like this and you were able to put the warmer.
I'm gonna be honest,
We helped hold it.
yeah, but like, there are IV warmer
But
bags.
I'm not finding them on Amazon. Amazon
And
has
he
everything.
laughed and joked the whole time on this.
Ours was maybe $5 cheaper.
And before that, he was in such pain, it was just.
Well, I'm just thinking, if you bought this
And I'm sitting there going, man, if I ever need anything.
and
I'll
you
have that
inserted,
Give me that. That's incredible.
Yeah, I mean, it was one of those deals where it was kind of.
that's kind of handy. It looks like it's got everything, the package for your fluids and then all your needles and everything you would need
Afterwards, I
for
looked at it,
starting
I
IV.
said, "That must have-"
That'd be nice to have like in your personal, of course I wouldn't be starting IV in my personal vehicle. Just to grab that, if you're going to work in a wreck, just grab that little bag. You're not fishing through our big honking bag where everything's just in there willy-nilly.
So.
That's impressive.
I agree, especially if we're gonna have like an influx of people who can do IVs. We should. Are you playing Dragon
I
Bane?
have no idea, but I just know whatever
This was bad.
they gave him that day.
I thought about buying my own AEMT pants instead of the overalls. I hate the overalls.
Okay.
I mean, it could have been whatever, I suppose, but.
But like, yeah, having all of this stuff for an IV and a little baggie that heats
Yeah, that's,
itself.
well, that heats itself would be nice, but.
Yellow
look at-
Mark.
look
You
at-
know,
Got it.
anything that would heat itself is good.
So we don't have that.
Freezing.
He was probably.
Have my other color.
Check this out, guys.
In the right position, the doctors tell us over the phone now.
Right.
you know.
Flipped over.
I thought about going to that truck and getting my
But see that, that one unrolls and it's all rolled up together. So you have all your needles and stuff there and it rolls up to the size of the IV bag, but
That's very nice.
looks nice.
How are you, Ed?
We need to yell at Mark to buy shoes.
Yeah, actually, it's really helpful. I
Search and
appreciate
rescue would,
taking time to do
you know,
this.
if you were
It's great.
just out.
So we're not looking at.
So
something
we
like that.
read all this stuff.
Oh, it's so nice to have you
Me
here.
particularly
He's doing such a good job.
medical background, so it's.
Not that I don't love Mark, but I
Neat
hate
job.
it when Mark
Trying to
teaches.
cellular structure.
I want to throw things.
That's how bad it was for me.
I want to throw things.
So.
I do that stuff too,
So yeah, it's really helpful to have somebody sit here and tell us practical stuff, you know.
Not going at the speed of light.
Well, and see, when I was with Dad, we were learning that stuff about, it wasn't, it was the chemo, about, like, one of his kids.
This is how I learn best.
Yep.
It's just listening and being able to ask questions and not
Yes.
trying to follow along
It was kind
at
of
the speed of light. I got nothing out of it.
I'm so nerdy, they all talk about it for me, so I'm like, okay.
Yeah.
Yeah, so he died back in August, so that's.
Congratulations on your engagement.
So, but you know,
Thank you. Okay.
Erin's one of my faves. Yeah, I am. I love Erin. She's awesome.
Yeah.
So I don't know if you noticed, but Erin treated me for my flight master
I offered.
Interesting, you
This is what I want.
tennis elbow.
Actually, this is what I want. The one that, see how it unrolls and you can put like all your needles and stuff?
I caught a lot of fish that day.
You do? In your car like here? I wanna look at it.
It was a really good day.
I don't have it with me, it's at home, it's sitting on my, on that little backpack thing I have.
Next time you're with, around.
I have a
me,
little
walk
IV
up.
stick kit,
yeah, I've heard a lot.
and it's just a little deal that
Yeah.
you use in and has
And does it
a.
hold a bag
Only
to
in
that?
Wyoming.
No, mine doesn't have a bag.
See, this one has, it holds a
What's your
bag.
tolerance?
So see how the bag is there and then it just wraps around the bag holding all your
I don't,
stuff.
my bag is separate, my little start kit thing, the little-
Nobody thinks it.
it has all my stuff in it for the start kit.
Cause you grab this and you got everything you need. I mean, I feel like even on the ambulance it'd be kinda nice to have instead of trying to fish through
Your bag.
our big bag that everything's just shoved in there.
I agree. That's why I like that
Just for
little,
starting IVs.
I like the little kit thing that I carry with me, but I don't use it very often.
I thought about getting some
Yeah, again, only in Wyoming.
EMT pants instead of the overalls
Right, Dad.
and getting those instead. Those new overalls we bought are terrible. They don't have any kind of
Yeah, I
pockets
feel
to
the
hold
same way.
stuff.
I can hold this thing.
Yeah, not even for your,
They're all overly
well, I guess
good,
that's for your
though.
family.
Texas, but still. Get up. We have 1,300 people in the town. I lived in it. There were 50 of us that graduated.
These are what I wanna buy.
The girls
I wanna get just a pair.
I'd say those for school, but other than St. Louis, this is the biggest town I've ever lived in.
This actually has restaurants.
Scrubs, man.
A hospital.
Scrubs don't have enough, like,
Where
all
I'm
the
from in Illinois,
pockets
it's not nearly as like
scrubs.
isolated, so like you literally.
Oh, I don't want it on my
live in
legs,
town,
like,
city,
I
like.
got
Or
more
on the map.
Well, when I'm sleeping there and I have, but when I'm sitting in the ambulance to work,
I have a friend
I've got them right here, I can cut whatever or do whatever.
right here. They're right on the
For your
Wisconsin
scrubs?
border.
Yeah.
They actually
I
have a
don't know,
church
I
in
think I might get some.
Yeah, usually there's a town I haven't heard of that's like
And you can, like,
by Chicago,
enter
like way north or way down
overtop, like-
south, like most of everything in the world. I'm familiar with.
They, well, like, she
I
has
just know that I'm
stage
over
one
the
diabetes.
overalls.
She's in
I hate the
Madison.
overalls, I think they suck, especially those
Well,
last
it's
ones.
a good spot, like, you
Yeah.
know, this
And
I
they
thought I
think
should
they
just
can
wear
get-
my, I've got my
they
Mortimer
can get it. The
little
problem
polo, I
is
could
that
just put it in my pants,
return.
where my overalls are and just grab those at night.
And she's only 40.
Hey, yeah, that's my
pants.
I want
East of
pants.
St. Louis.
They're like, ones I found that I liked are like $70. $5.11, these are $5.11, I guess they're
How much are
40.
uniform cost?
Kind of like Dallas.
No.
My cousin's husband,
So there's some places.
There's
years
some
ago,
khaki
used to
ones.
run the,
For
rec centers.
74.
I like.
Just take that off of that lake road.
This is where he started. He took.
I don't know,
what do you think?
Mine
Went to
is so
some of
bad
those
because
rec
I watched it
centers.
so much since COVID.
Man, he had
It's
some
like
athletes in
falling
there,
apart, all
guys
the
hanging out at the rec centers that were flat.
They were like.
But I also don't want them so tight that.
I mean,
And
yeah, I mean, they had guards then, they had security.
I don't know, really?
Man, I couldn't imagine that.
I also really like
So, my overall.
We didn't get into it.
Are you in your chair? Rude.
I'm good, thanks, I don't, not
There's some neat agricultural areas there.
limited
I
on
love
how
that
much
part
of
about
that
it,
stuff.
Some big deer too.
The hospital.
That's kind of
So,
the
yeah, I
big
think I
deer
might buy
hunting
some
place.
London.
Yeah.
Did you see the hats that we bought?
I go back in November.
Do you?
Yeah, my farm's sold, well, I've been hunting sold, so I
Can't
don't,
go down this.
I might try Montana this year or something in November, but.
Yeah, that's what I think.
I don't know what I'm gonna do. Eventually I wanna buy a
Yeah.
gun, just not
Yeah.
to go back.
And it's charges, you just,
I wished
that's the one I bought.
I didn't have any money, so it was easy. But,
But,
like I think I told you, like
Right.
the Koski's bought
yeah,
the place.
so like I have a little like
Yeah.
this on the brim, and when
That's-
you
Well,
try to
that's
get
Southern
the
Iowa.
right spot where this.
Yeah, it's unbelievable, and you couldn't
I bought-
hardly give land away
I
back
bought my
when I was a kid. I mean,
See, that's crazy. Now it's like, oh, I'm gonna have to save forever. Just even think about it.
My dad, my uncle had a farm that he was, that went bankrupt. He had been renting and the people put it up for sale. My dad could have bought it for like $60,000. And it was
Well, I thought
180
you were wearing
acres.
it.
You were wearing it the other night when
Oh.
I got my.
For a
And it
period
was,
of time to wear
I hate
it,
to say,
but
not good ground.
you're out
Yeah.
on scene at
It
work.
just kind of, you know, you always fought the brush and there's
Where are you
some
going?
clay and everything else. It wasn't really high productive ground, so my dad wasn't interested in it. But like now, that land commands a
Hey,
premium over the better farm.
Mark, that pedestrian, did he
Yeah.
survive?
Country in Pennsylvania.
Yeah, so.
All of like the lead Tiffany those shows have just inflated everything.
Oh.
Okay. So we saw
Days
it.
before he was hit.
Yeah, it was,
But he's still alive. What was that? I talked with her brother.
my cousin still owns the
Is that
40
fine?
acres next to the Koski's
I
there.
think he's like a professional
Or
fireman.
my uncle's home parents. It's, well, it's still there, the whole place is still there. They would like to
He
use
used
that
to
to
sharpen
add
his
in
for
there.
BBs.
Should I buy now?
They've offered to, if they
I
want to
was
sell
bummed
it.
that
they
Nellie
can use it for dating.
Gorley died. I knew she was sick, but dang, I liked her.
They bought up a
I always
lot.
tell her to behave herself in
It's
church.
amazing.
Meet the lady. Did you hear that guy that Nellie died? Barb's
He
mom?
came out of like Minnesota or something.
And then Ryan O'Connor's dad.
I've never met
car
them.
accident, Torrington.
My cousin says they're nice folks.
They said at the school. He was
They have a,
teachers there.
I don't think they use it. The guy before them.
It was the same, I found that out the same day that I
was from
found
over in
out
Illinois.
Nellie
He
died.
built a clubhouse. Cause he had,
Service is supposed to be today, but I have to.
yeah, clubhouse stay.
Monday morning, but like,
Definitely
It sits
knows.
down there below my uncle's house about
you would have Friday.
3-4
Did they
yards.
call you
I don't
out?
think they even use it anymore. It was kind of a neat
I
little
didn't
place.
know
He
it
went
was
there.
on you.
I was over there when the guy first built it.
What are you doing?
That's awesome. That's the dream someday.
Yeah.
The thing I don't know is even if I could save enough, it's like, I want so much money, what they want for that ground nowadays, like in the ground that's 18 hours away from me. I mean, my family's still there, so I still love to go back, but.
You know, when he was little, he had a pulley
Well,
system, he had a
and
bunk
what
bed.
could you do
So
with it?
I let him put a pulley
Well, that's
system
fair. This is
up,
because I thought about, like, if I ever could buy it, do I wanna buy it here?
in his room, and he
Or
he
do I
had
wanna buy
a
back there?
fridge
So
where
I
he
wanna
could
go
turn
back.
his light off.
Because I love going back, and there's public.
It was like
I
turn
can't
my
believe
light
I
on
like
at
Back there, you
it.
like.
It screws in
cash
the
rate
wall,
right
and
now,
I let
like,
him.
farms around here bring anywhere from 250 to 400.
Yeah, they
Or
were
sure,
Just
that
cash
it turns on your
rate.
lights.
Do a thing too, it just lets them make farming.
It was mostly
Can't
for
do that
me,
here, that's
so I didn't have to get into.
No, they don't bring
Every
that
time
much
he
here to
he'd
rent.
go show up in
I've heard people here saying, "Can you give somebody?"
Now I fully don't know how.
So I don't know how true that is, and it's good to figure out. I think somebody would jump on it.
I think somebody jump on, it just depends if, you know, I mean, I know what my cost is per acre to raise hay.
How many of them were
Boy,
COVID
before I
last
rent
year?
something.
They are all
I look at
difficulty
it.
breeding.
They were-
So
none of them
I
were
was like,
COVID.
oh, good.
It's
Cause everything came over difficulty breeding, I'm like.
Fertilizer, you gotta have all your own equipment, you gotta have to bail it all, there's, I hire somebody else to do the baling. It's not cheap, I mean, you're talking $55 a ton to bale.
What's it sell for? If you're gonna sell it.
Depends on the year, you know, this year, gosh, you could probably
We
get
had our drunk
He
down.
wasn't even drunk.
$140 to $150 a ton this year, but a year ago.
Look at what's the difference between drunk.
Top of the market.
Oh, yeah? Oh, really?
And it all started
But
like.
the thing is, like,
it was actually supposed to
so if
be-
you rent it out, you're not gonna get rich for it.
You had one Bloody Mary and one
They want
Fireball.
like the prices for ground here,
That's
so like.
interesting combination.
Also, yeah,
It's crazy
It's
expensive.
not as high as it is there.
Trying to get it
instant
All
fun.
that.
Yeah.
My mother-in-law just
You
sold.
drink that Bloody Mary, you taste it in the
and it's just.
I mean,
sold
Fireball
her
is
family
different.
farm. I think it came to what, 7,000 or 8,000.
Really?
Wouldn't
It's like pretty nice ground, it's like still.
Fireball?
I mean, some of it's been 12,000 an acre, but you can buy some pretty decent stuff for like.
Did you ask,
Still averaging.
Sean about his like,
$4,000 to
his plane ticket?
I
Tyler,
will not remember. to
Yeah,
do
her ground was
that.
up in northeast.
The honest
Wanna
phone
know
number,
if he's
I'll
got
give you
it?
the phone number.
Any hot springs?
no, just ask him.
Next time you see him.
Though
No, I
it's
forgot
not
you
really
know.
agricultural, but it's right next to
Miller.
some big timbers.
Did go to
Line
Hawaii
straight
this
through
summer.
with a spring that
when you attempting to go.
So that made it, you know, pretty desirable.
July,
But I think it just sold for
20th through the
7,800
24th.
an acre. And that was to another family members, so I don't think they were trying to.
Wanna go?
The Dominican Republic.
Just kind of the-
but-
Like, out here,
Can you watch
you're
the
looking
States?
at, well, it's just be a ranch deal. I mean,
It'll be
I would
fun.
look at more like on.
We'll crush the crap out of it.
Or whatever.
Well, Owl Creek is
You
cheaper.
go to church and say I took your prayers
Because you get paid out of
forgiveness
water.
for a while.
Okay, how
That's
does?
the
There's still like,
Well,
like
Carl
when they're
Cameron
even
bought
like
this
$4,000, $5,000, $6,000 an acre or more, is that kind of what you see?
Oh, I'd
Not
say,
much it comes to for sale either, that's it.
yeah, I'd say probably
Go to
two.
Genesis
to
because
3,000.
Uh-oh.
For irrigated ground.
Yes, I do. Yeah.
It just depends on how
Cammy's
much
pretty
rain
hero,
there is.
Carl.
Well, I mean.
Colorado.
What's the point? We're gonna be
Well,
done
hey,
in a little
are you ready, Dan?
I'm ready.
Alright.
I'll get everybody whipped back in shape.
All right, kick into teacher mode, let's go. I know you have one, I've seen it.
Me?
Your teacher mode, yeah.
Oh,
I got one too, I don't know if you picked up on that.
You do?
Yours doesn't involve this though.
I pretty much live
the
in that
flicking
mode.
of my hair.
Those fingers are gonna come
One time to go on a corner call.
Okay. Dale, is Dale coming back?
Dale ran home, that's all I know, I saw him go up to his house. so I don't
I'm
know.
pretty sure he wouldn't want you to wait for him.
Mark had a phone call of some kind, so I'm not sure if there's
The corner.
Corner call.
a coroner's case. He had a body somewhere that needed to be
All right,
We'll get back at
As
it.
long as it's not Pioneer Home, I'll be all right.
I'm gonna go to section 4 of my handout, which is classifications. I think we're gonna talk about drug classes mostly. So we're gonna talk about body systems affected. I don't know if there's much to say about that. I think we're all pretty familiar. You guys have decent understanding of anatomy already. It sounds like you talked about cells and whatnot. So, and we talked about the
The
drug.
teacher was pretty lame, but.
We talked about the the different, mechanisms of delivering a drug and how that can be, go in hand with body systems and what you're trying to affect. The one thing we didn't talk about that we might cover is the blood-brain barrier. And so, again, it's very hard actually to transition from the bloodstream into the central nervous system and your brain in particular. There's, they call it the blood-brain barrier. It's basically I assume like a lipophilic coating that you have to get through. So a medication that might easily dissolve in your bloodstream, which is more like probably hydrophilic, may not be able to cross into that fatty material as easily. And so the one situation that really comes to mind that affects us commonly is with antihistamines. So what's the #1 side effect of Benadryl?
Pass out for a year.
Yeah. So Benadryl's very effective at crossing the blood-brain barrier. It's a first-generation antihistamine, H1 antihistamine. You have 2 histamine receptors. There's H2s and H1s. And so Benadryl is a first-gen antihistamine, H1 receptor blocker. And so, antagonist. And so then there's like Zyrtec and Allegra and those things. Same stuff, like usually for allergies too, right? But what do they not have? They don't make you sleepy, right?
Right.
They still could a little bit depending on your
Night
person.
tremors and hallucinations if it's Zyrtec.
Really?
That's why I don't take Zyrtec anymore.
So I dream very vividly when I take chlorpheniramine, which is like a derivative of Benadryl. It's a first gen. So antihistamines as a whole, I think, can definitely have, if they have that sedative effect on you, that they can cause some weird stuff for sure. So anyways,
That explains.
don't go abuse Zyrtec now. If you're binge drinking and
Yes,
drinking.
you know how I am.
Let's try something else.
Caffeine does the same thing to me, so.
I'm a.
He's gonna be disappointed if it doesn't work.
Desensitized to caffeine, so.
So anyways, those drugs are second generation H1 blockers. And so they're second generation and they were designed that way in particular because they don't cross the blood-brain barrier. And so you can hopefully still get the antihistamine effect, which is, suppressing your allergies, but not make you drowsy so you can function during the day. The problem is, although they're still fairly effective, they're not nearly as effective as the H1s that do cross the blood-brain barrier.
To be
First
fair
generation.
though, you can't have allergies if you're in a coma.
Yeah, that's true.
Don't have the symptoms.
You're not aware of the symptoms.
Yeah, effective.
Yeah. So that's one case. I'm trying to think if there's anything else that. Nothing else is coming to mind. There's definitely other instances like that where some drugs are better than others at crossing and some not. Maybe on that note, we might talk about metabolization a little bit again. I want to rewind. This is probably going back. This reminds me of another concept though. But like, anybody ever heard of amoxicillin clavulanate?
One more time?
Amoxicillin.
Amoxicillin-clavulanate.
Mm-mm.
So Augmentin, maybe more common.
Yeah.
Oh, okay, Augment, yeah.
Yeah, so much more, it's easier to say Augmentin, so no one calls it the other. But the thing about that is so this is another situation where like combination, and that's not a salt, okay? That's a separate product within Augmentin. And what that's doing is inhibiting the metabolization of the amoxicillin. And so in the case of that antibiotic, the bacteria actually develops a mechanism to break the antibiotic down before the antibiotic can get to its cell wall. And so that is a pharmacology engineering concept to prevent that clavulanate blocks the antibiotic or the bacteria's mechanism so that the amoxicillin can work. And so there's bacteria you can treat with Augmentin that just plain amoxicillin won't work on. So you see that a lot with antibiotics. There's other medications, one carbidopa levodopa, which is more so for like seizures and whatnot. The hopefully don't tell you, I think it's the carbidopa is the active ingredient, and the levodopa stops the metabolization so that it can stay in your body long enough to work. That may be backwards, so please don't quote me, but either way, one stops the metabolization of the other so that it can work, because if you didn't have that other one, it metabolizes so fast that it won't do anything, it doesn't work. So that's another instance where it's not the salt, it's a combination. And usually, in my experience on labels, you'll see the one dash the other word, as where when it's a salt, there won't be a hyphen in the middle. So that can kind of help you tell the difference between the two. So hyphen means combination, no hyphen, probably a salt. And usually you'll recognize the salt name, whether it be sodium or something similar. All right. Classifications by body system. So we're gonna talk about the central nervous system, autonomic pharmacology, cholinergics. We mentioned this already. Cholinergic side effects are, how I was taught it in school, is SLUD, okay? So salivation, lacrimation, urination, and defecation. Those are what cholinergic side effects are. And so anticholinergics reverse those. They're anti-SLUD is how I was taught. And so actually diphenhydramine, those antihistamines have anticholinergic properties, and so does atropine. And there are several others as well, but they're gonna reverse those symptoms. And that's kind of the Lamodal we talked about, the atropine diphenoxylate. It's that atropine and diphenoxylate that are reversing that diarrhea by being anti-SLUD, if that makes sense. And that's why the antihistamines work, is because what's happened, what are you trying to treat? Well, your nose is running, your eyes are watering, you're itching, so you take that diphenhydramine and it dries you up. So that's kind of what's going on there. Adrenergics, you're gonna see this more with, let's see, potentially epinephrine and a few other meds. A lot of your cardiac meds, whether it be for blood pressure or heart failure, you know, I think about metoprolol, if you guys have heard of that. Let's see, a lot of, pretty much anything that works on the heart or vasculature. Albuterol is another good one. These ones are gonna classify as anti-adrenergics, usually, or adrenergic in general. So there's alpha and beta receptors all throughout your body. Beta 1, beta 2, alpha 1, and alpha 2. A good way, who's heard of a beta blocker? Are we familiar with those? Okay, so metoprolol, propranolol, those olols are the beta blockers. They are beta 1 receptor antagonists, okay? So you guys already know beta blocker, you already know it's working on the beta receptors. And so the simplest way to, those beta blockers reduce heart rate, right? So you have beta 1 receptors in your heart, and you have beta 2 receptors in your lungs. This is the easiest way to think about it. So think of B2, I've got 2 lungs, that's a 2. Of B1, you got 1 heart, all right? That's how I remember it. So those drugs we just talked about, they're beta 1 receptors, and that's why they decrease heart rate. Where some of your others, I just want to check something real quick, guys, if you'll just give me a minute. Some of your blood pressure medications are going to be like alpha receptor antagonists, and so when you stimulate these receptors, you're usually going to get an increased effect. And so if you stimulate a beta 1, you're going to get more heart rate. If you stimulate an alpha, you're going to get vasoconstriction, because it wants to think about kind of like in the terms of like fight or flight. Stimulating those is your fight response. You're going to get ready to run, get ready to go. As where antagonizing them is the opposite effect of stimulating, right? So then you're going to get slowed heart rate, which is what we want in heart failure, because your heart's working too hard. We want vasodilation, which will decrease blood pressure in the case of blood pressure medications. In the case of like albuterol, it's going to bronchodilate, so you can't breathe, right? Because whatever's going on. And so you give an antagonist to the lungs, and it lets those airways open up and relax. So most of these medications, all these adrenergic medications, are just working to relax and alleviate symptoms. Now, you can stimulate those mechanisms as well to get the opposite effect, but it's usually less common that that's the case. Do we need to pause for a minute for them to get
Yeah,
out?
just a sec.
Okay.
Does it just keep dropping them?
It's because it's a free account, so
Oh.
there's a 1 hour limit, and it's probably because we have more than one person on the video now.
Cause Brandon's still there?
Yeah.
Better be listening.
He is, I've been texting him.
Boy, good boy.
So, like albuterol would also affect your beta 1, because I know that when I take an inhaler, my pulse skyrockets.
Yeah. So the main intention of albuterol is to be a beta-2 receptor antagonist because you want it for the airways. But it's really hard to get selectivity sometimes. When you target a beta receptor, it's like, how do you stop it from getting to the beta-1s when you just want it to get to the beta-2s? And so there's levalbuterol, if you guys have ever heard of that, Sopanex. It's darn near the same thing, but they use a different isomer. And so it's better at targeting beta-2s as opposed to the beta-1. But with albuterol, you're exactly right. We gotta be really careful, especially in the ER, because patients will come in with like tachycardia, and you give them that albuterol, and you can make it worse, and then you increase stroke risk and heart failure, MI, things like that. So, good to go? All right, so, yeah. Like we'll just reiterate that for them. So what we were talking about was that albuterol is intended to be a beta-2 antagonist, which would work in your lungs to open up your airways so that you can breathe better. But the problem with it is that it's really hard to get exclusive beta-2 stimulation and not get the beta-1 stimulation. And so, and by stimulation I mean antagonism, I'm sorry. And so you do frequently get tachycardia with albuterol. And so we were talking about how there are other forms of albuterol, such as low albuterol called Zopanex, that is, when they're formulating it, they use the other isomer to make, and it just for some reason makes it more beta-2 selective. So you get less heart rate increase and more of the intended effect in the lungs.
So why would they not then prescribe that kind rather than the albuterol for like an inhaler and stuff?
Expense.
Okay.
Yeah, there's a lot of it. It's harder to make the other one. So I'm not a chemist by trade, and so this is hard, but like whenever you're with molecular compounds, there's an R and an S isomer, like which are basically like inversions. If you can kind of think of them like a mirror image of each other. If you think about like with your smartphone, when you take a selfie, everything's backwards, right? But it's the same, but it's backwards. And it's that concept right there with chemistry that can make all the difference sometimes. That's my watered down version of that.
Works for me.
If I was an organic chemist, I would have a better explanation. But yeah, that's kind of what it is, and picking the other one. But sometimes it's harder to isolate one or the other, I guess, maybe, and it gets more expensive, and you know, that's stuff that I don't dabble in, but that's what I see. So, let's see, any questions on the beta or alpha agonist or antagonist? Okay, so, let's see. So you can get, I guess the only thing I would add on, this is probably, you guys probably won't need to know this, but if you're interested, some of the beta blockers that we talked about, the propranolol, metoprolol, like that, some of them are beta-1 selective, just like the albuterol. You run into the same problem with them crossing over to beta-2 receptors, and I think you can find, I think the biggest problem with those is that you can find beta-2 receptors in the vasculature as well. And so by antagonizing both, beta-1, you get decreased heart rate, which is usually intentional. When you decrease beta-2, sometimes you'll decrease blood pressure as well, which is counterproductive because sometimes they don't have good blood pressure anyways, but their heart's beating away trying to make up for it. Because everything in your body is like a, it's always a cause and effect system in reverse inhibition and vice versa. And so you get less blood pressure. What does your body try to do? First it wants to vasoconstrict. That doesn't work, then it increases your heart rate. And you can exhaust that heart, especially in somebody who's frail and can't maintain that blood pressure. So, but as a physician, you don't want to give them something that's going to lower their blood pressure too. So then you pick formulations of beta blockers that are beta-1 selective for the same reason, like you were talking about. Sometimes we don't want to increase that patient's heart rate, but we want to open up their lungs. So it's a the right word. It's a little bit of a puzzle sometimes finding the right drug that does just the right things for that patient. So, and again, then you get into the horse and cat concept where it's like what works for that person, even though this should be what's happening. And it really is just a puzzle. Each patient is very different, trying to get the right intended effect at the right levels. All right, so now we're gonna go on to analgesics. What's analgesia?
Something that's on the surface.
Relieving pain.
Yes, relieving pain is the right
That's right.
definition, which is,
I'm thinking analgesic balm, so.
yeah,
that's
and
what I was-
topical analgesics is very common. That's right on the right track. And so we've already spoke about opioids. Let's name off the opioids that are most common.
Morphine.
Morphine, good.
Heroin.
It is an opioid, you're right. It's a C1, it's a
I
Schedule
mean,
1.
it's
Fentanyl?
not medicated.
Right, yeah, not medicated. Fentanyl, yes. Oxycodone. So, and I would elaborate that that's oxycodone, OxyContin, Percocet, or all oxycodone formulations. You said Vicodin, I think? Yep, so that's hydrocodone, which is also Norco, Vicodin, like you said, Lortab, all the same thing. Let's see, what else is there? So, did you say one? Yep, Dilaudid, that's hydromorphone, good. There is, let's see, we talked about morphine. I believe,
Opium.
yeah, well, yeah, it's pure form.
Smoking it in a pipe.
Well, the only thing else I can think of right now is codeine, plain codeine. And so you can, like I said, codeine's metabolized like into morphine basically. But it's almost, I've never seen it plain. I don't even know if they manufacture it that way actually, but I know it's a C2 if it's plain. And it is an opioid, but in formulation you'll see it combined with another product, whether that be guaifenesin or acetaminophen, and then it becomes a C3 through 5. But it's still technically an opioid. And so,
I've seen it manufactured plain on whatever that, not Live Rescue, but the police one, you know,
Okay.
this guy says stole it from a pharmaceutical company and it was bottles and.
wow, okay, so maybe they do. Interesting.
You get it here.
Not legally,
Pre-med.
probably.
Yeah, yeah, but of course. So codeine is, anybody familiar with what we usually use codeine for? Because it's not normally pain.
Cough syrup.
Yeah, good, yeah. And so opioids as a whole have cough suppression, respiratory suppression, cognitive suppression. They're suppressants, depressants. So if you find you guys know what opioid overdose looks like? Anybody experienced that?
Can we review that? I don't know.
Yeah, so first thing you're gonna see is maybe they start seeming a little drowsy, and maybe they're breathing a little slower. So we watch respiratory rate a lot. Normally I think somewhere 12 to 20-ish is normal. I think that's right. And so you start seeing them dip into the low teens or even single digits especially, you can assume that something's going on. And then, I guess just general lethargic responses, things like that, cognitive impairment. I think you could definitely expect to see some heart rate decrease, maybe some bradycardia, that's possible. And then,
Pupils.
yeah, pupils would dilate, right? And then after that, if you start losing consciousness, then that's normally the next step.
Thanks.
Yep. Okay. Let's see if there's anything else. One, not opioid, but fun topic. What schedule is cocaine?
Two.
Schedule 1?
It's a 2.
Yeah.
Oh, okay.
Yeah.
I guessed, because I figured it was too easy to be one.
Yeah.
I was gonna
So it
say-
has a therapeutic purpose.
There is a
Yeah.
therapeutic purpose.
Yep. And so cocaine vasoconstricts, essentially like an alpha agonist. And so like in the case of like nosebleeds that we can't get to stop, you can atomize cocaine and it'll constrict the vasculature and stop the nosebleed.
Whoa.
Nice.
Yeah.
Wow, that would be an improvement over the deal where they shoot it up your nose and it expands the
like the swab.
Yeah,
or
the tampon
nasal
looking thing that
rocket,
they jam
yeah.
up there and let go. And
No, that's what
nobody
probably-
seems very happy to get those.
You're probably gonna get that first. So, don't be running into
Little
any
direct
doors.
pressure before the cocaine.
Oh, man, I got a nose for cocaine.
I don't think it could cause that.
Maybe don't advertise that in town. That's between us, okay, guys?
That's it.
Two insiders.
High school kids.
Yeah, I can only imagine, like, I'll go to the next month to that, like, nosebleeds are up 5,000% this month. What's going on?
People are just running into doors
The
left and right.
EMTs though.
No, cause we know, I've seen the other thing shot up there and it's
Oh, yeah.
not pleasant.
Yeah, there's lots of stuff we would do first, like that, and like there's oxymetazoline, which is Afrin, you know, normally used for congestion, does the same thing though.
Oh.
So, that's like last line, we rarely do it.
Yeah, the little tampon things look so good.
Boy, they hurt. Nobody
Yeah,
gets
I've
those
never
is
done
very
that.
happy.
I think I'd rather have like a machine or whatever you're talking about do it than a wrestling manager. They're not gentle.
Trust me, they're not gentle with the other deal either.
They're not.
Okay.
So opioid antagonists,
Thank you for.
who knows what that is?
Something that would work
Reverse
against the
the
evil
opioid
force of
injection.
So would Narcan then be that?
Yeah.
Good, yeah. Okay. Right, yeah. That's pretty much the big one, is Narcan. There's others, but that's the one you guys are gonna use. Non-steroidal anti-inflammatory drugs. Anybody seen these before?
NSAIDs.
It's,
Yeah.
take some periodically.
Yeah, most people are pretty familiar with those. I feel like, do you guys wanna talk about those? Is there any questions on those? Are we comfortable? Let's talk about, I guess, common adverse effects is probably decent, worth knowing with those. So an NSAID is anti-inflammatory in nature. So it's gonna decrease inflammation, it could, and honestly, they can increase blood pressure, but the biggest thing with an NSAID is that whenever you take it to absorb, they cause like a lot of like gastrointestinal bleeding. And so when you take it on an empty stomach, or even when you take it on anybody that takes an NSAID, even with food, is still gonna have some level of bleeding. It causes the vasculature to get very irritated. So you can cause like a lot of like GI irritation, GI ulcers for chronic NSAID users. So,
I have a friend that her husband actually had to go by ambulance because he was in his office and I think it was his knee, and he had just kept taking ibuprofen so much that he was bleeding out quite a
Yeah.
bit, and he had to go by ambulance on that one.
yeah, so you definitely wanna be careful with that. I don't have much more to say about it, other than like, if you know somebody taking NSAIDs, tell them to take it with food, follow the dosing schedules, don't overdose. And if you have somebody.
Long term, can't they have some renal failure effects as well?
Exactly, yeah. It can actually, the effects of NSAIDs are almost like, it gets pretty ambiguous, but they can be not great for your heart, not good for your kidneys, not good for your GI tract. It's another risk versus benefit thing, like anything in medicine. But you can do things too to help too, like if you know somebody's taking NSAIDs constantly, like that person was probably taking, if they're taking it over the counter, that means they're taking a bunch of, like, if it's ibuprofen, a bunch of 200 milligram tablets. All that extra surface area causes more irritation in your stomach, and so that's a case where a larger dosage in a more solid, like an 800 milligram tablet once, instead of 4 200s, is gonna be better for your GI tract. So little things like that can make a difference, which you would have to get a prescription for that. So
And
there's.
so we don't, I know, like, I don't think about, I'll take
really guilty.
ibuprofen and.
Just at the very least.
You're talking, I'm like, oh.
Make sure you take it with food. That's the best thing you can do is eat first.
Should probably inform every sports team in our high school about that. All of them.
I'm bad about taking my stuff, and I know you've chewed on me for that before. I don't know if you remember it, but I do. I didn't listen.
It was a good chewing.
So
Well, and I'm guilty. I've used NSAIDs. I try not to. I mean,
yeah,
as best I can, I know.
NSAIDs are good for inflammatory pain, but for just general pain, there's probably a better choice. And unless you have some sort of liver complication, and that's acetaminophen, because it doesn't have the same adverse effects.
Okay.
I mean, in excessive doses, it's hard on your liver. Long term, it can be stressful on your liver, but it doesn't have the GI bleeding. It's not as known for the kidney problems or any of the organ system problems, and so now if it's straight inflammatory pain, NSAIDs are going to work better, and you'll know it. But if it's just like, you know, earaches or sore throats, or maybe I have a bruise or something, you know, like acetaminophen, yeah, headache, acetaminophen's probably a better choice in those situations.
I'll switch.
So like in the case of you guys are interested in the COVID vaccine, I don't know if you guys have heard, like they're saying like, you know, you don't want to take a bunch of NSAIDs thereafter if you can avoid it, because it's going to suppress your immune system. So that NSAID, anti-inflammatory response, the immune system working is inflammatory in nature. So that's true, and so I would recommend, you know, if somebody has problems, if you can avoid it, don't take anything, because if you can tolerate it, then get the full immune response. But then I would recommend acetaminophen first for those same reasons, that you're not getting that anti-inflammatory suppression that acetaminophen wouldn't have.
We should have had this class last week. You've done everything wrong.
So, I mean, that said, even NSAIDs, acetaminophen, yes or no on either one of them, like, the response from the vaccine is not all or nothing. Like, you're not gonna shut it off because you took an ibuprofen. You know, it's still working.
And I am way better than I used to be about taking it. I don't
Yeah.
think like I used to.
Now to say like, I mean, I don't know. It's very subjective. Like, is it gonna be 100% effective or maybe 98% effective because you took an ibuprofen? Like,
Yeah.
you know, it's still working. It's not gone.
It didn't help the headache either,
Yeah.
so.
Yeah.
Okay, learning lots of good stuff here.
All right. So sedative. We talked about benzodiazepines. Let's talk about those. Which ones are those again?
Oh, I wrote it down.
Yep. Good. Ativan, which is lorazepam. Xanax, alprazolam.
Mama's little helper.
Go ahead.
Mama's little helper. Valium.
Valium, which is diazepam. There's
Sorry, that's a 60s thing.
one more pretty helpful, or pretty common one. Versed, midazolam.
Oh, there you go,
Okay.
that's the good one.
Okay, so what do those do? Remember what that class of drugs does?
Sedative.
Depressants.
Yeah, depressants, okay. A little bit like opioids, they really cause respiratory suppression, so the same thing, and then, you know, after that, you're probably unconscious if you overdose on them. So it can look very similar to an opioid overdose. Frequently, prior to a urinalysis, we don't know if a patient's overdosed on benzos or opioids.
So, I know that we have like Narcan, but is there an antagonist for benzos?
There is, yeah. Does anybody know it? It's flumazenil.
Flu what?
Flumazenil. Flumazenil, I believe.
I don't think that'll be on the test.
Yeah, I don't think you guys have that on your list that I've seen.
Okay.
ENIL.
Good, okay, not an A.
So I assume the reason that we, like, police officers and the general public don't carry around that is because, I mean, is it because benzos are less abused on such a wide scale?
I think so. Heard overdose on, as opposed to like heroin or, you know, heroin laced fentanyl. That heroin epidemic is really what's driving the Narcan to be accessible to the public. You know, it's so potent. I think, isn't heroin like 1,000 times more potent than fentanyl or something? You know, and fentanyl's the strongest. Is it more?
I thought
It's- I
I thought
think
it was the
it's
other way
the other
around,
way around.
fentanyl was more powerful.
Yeah.
That's what I thought.
Cause they cut heroin with
Oh.
fentanyl to make it,
Oh, maybe you're right. I'm not sure.
give it more kick or something.
Yeah, well, okay.
Mandy,
Yeah.
you probably know that,
Is that right?
Fentanyl's-
Fentanyl's more. And that's, yeah, cause fentanyl's in micrograms. That's, I think of it kind of backwards, but okay. Yeah, so.
And they do use fentanyl to cut heroin.
Yeah, so either way, like both of those are very, very toxic. Or not toxic, but easily overdosed on because they're very potent is the word I needed. So I think that's the driving force, is where benzos are much harder to overdose on, it's much harder to die from a benzodiazepine overdose. That's what it comes down to. Where opioids, like, you know, they can be quick. So as far as the side effects though, I don't think it's really super risky, but in the hospital, a lot of times we'll be giving both intermittently to try to figure out which one's working if we can't figure out what substance we're dealing with. Barbiturates are much like benzodiazepines. Don't really, honestly, I never use them. I never never seen them used in the hospital. I think maybe once or twice in my 3.5 years here, I've used barbiturates. But depressants, again, I don't know that there's much more to be said about that. Phenobarbital is the most common one that you could come across, but I would expect the side effects to look much the same. Anticonvulsants, so convulsing seizure, right? So we're gonna stop the seizure. Anything, whether it's cardiac, because cardiac, your heart's a muscle, right? Or anything that's muscle related, everything that happens, I don't know if you guys saw this in your anatomy, it's all action potentials and it's derived from electrolyte balances. And so from inside and outside the cell. So you have your vasculature, and then outside of the vasculature, you end up with in the extracellular space. So it's just like this, like, I don't know what to relate it to, but it's just this open area where there's fluid and electrolytes and whatnot. And then you have the cells. Okay, so like, I guess a good way to think about it is our veins are like the streets. There's the extracellular space, which is our yards, and our cells are the houses. Kind of like that. Okay?
That's a good analogy.
Yeah, and so your veins are transporting everything that needs to be everywhere in your body, protein, oxygen, electrolytes. But then that stuff can cross that barrier out into the extracellular space and then interact with the cells. It has to be transported. And so seizures are caused whenever you get, well, okay, I'm not gonna go that far. The action potential that could cause a seizure or any muscle contraction is caused by the moving of those electrolytes. So you have potassium, which is a negative charge, and then sodium, which is positively charged, I think.
No,
It's backwards.
they're both positive. They're both on the.
No, yeah, they are both in the.
Oh, but in the body.
On the non-metal.
They have to be opposite
Yeah,
to
they're
have.
both on the metal side. They're both on the left side of the periodic table in the alkali metals. So they would
Yeah.
both be a positive charge, because they would give up one electron.
Yeah.
K plus.
So
the opposite of.
most of the action potentials are driven by calcium in the heart, and then potassium and sodium in the regular
Sodium,
muscles.
potassium are +1, calcium's a +2.
So you've got like chlorine, phosphorus on the other side of that?
Yeah. Phosphorus is -3, chlorine -1.
I'll pull up the action potential real quick. We'll get it
I
right.
A
remember
little bit
learning
higher
about-
level than I teach at 8th grade.
I remember learning about potassium pumps, but I don't.
Yeah.
know
Yeah, I
much
can't
more than
remember
that.
potassium pump and.
I remember the sodium
Your
potassium
sodium
pump
pumps.
from my anatomy class, from my physiology class.
What did they just?
But it was really funny because I just helped Jaden finish out the chemistry for the, and then I'm going, really? And so I'm like, look, this is why you just did all of that.
Yeah, so I don't know that did you guys have to learn action potentials? Was that in your?
Physiology back in college.
Not in this.
Oh, not
Okay, well, let's not stress on that.
If we did, the teacher didn't talk about it.
Okay. Yeah, I mean, that's another thing, like what I'm concerned about in medicine is like, I see your magnesium low, I'm gonna treat it. I see your potassium's low, I'm gonna treat it. It's high, I'm gonna treat it. Like, I don't necessarily get too wrapped up in the physiology anymore because it doesn't affect the patient, but I just understand that that's what's going on, is there's a flow, like you said, the potassium, or it's potassium pump. Is it sodium potassium
Sodium
pump?
potassium pump.
Yeah, good. It's been a few years for me. But just understand that gradient's happening. And so imbalances in that gradient, or the inability to repolarize, can cause prolonged muscle contractions or arrhythmias and whatnot. So that's what's all driving it, is these electrolytes, basically.
And low potassium can go for like crap.
Yeah, for sure.
So you were saying what causes then the seizures?
It can be a combination of things. It could be neurologic, it could be the central nervous system malfunctioning, but it could also be, electrolyte imbalances and things like that. Stimulants, I think we're pretty good on that. They're just, the opposite of a depressant. They bring you up. I think I kind of breezed through these drug classes in the book, and I think that's about the depth that they covered in, was just not necessarily needing you to know examples of which one or being able to classify, but just understanding what that drug class does. Is that your guys' understanding? Okay. So, antidysrhythmics, that's a really complex way of saying just an arrhythmic or antidysrhythmic I guess that is the proper way to say that, but nobody says that actually, so. Basically, it's just a drug that is stopping an incorrect rhythm within your heart. And so you can think about like amiodarone, digoxin, anything that's correcting a heart rhythm can be classified in that. And actually, I think digoxin is actually classified under a cardiac glycoside, and that's the only one as far as I'm aware. But there are a lot of antiarrhythmics in medicine. It's as simple as they're just correcting the heart rhythm. And digoxin really helps with elevated heart rate, tachycardia. It helps control that in patients that are resistant to other medications. So
It's more common to hear it called antiarrhythmic than antidysrhythmic.
Yeah.
Is what you're saying.
Yeah, that's how.
Yeah, cause I'm on a couple of them and I've never heard the dysrhythmic.
Yeah, so, yeah, I guess it makes sense though, because you have a dys,
Yeah.
which is bad rhythm, and it's
So it's
anti that, so.
Trying to correct that,
Yeah.
that makes sense to me.
I'd say we just probably shorten it. So we're not choking on our syllables.
Does that mean you can dance better?
What's an antihypertensive?
It lowers your blood pressure.
Yeah.
Reverse it.
Good, so,
Lisinopril.
yeah. Let's see. Yeah, not too much there. I mean, anybody that takes an antihypertensive could have low blood pressure, right? Let's keep that in mind. So I'd say most commonly, somebody who's newly on it, they stand up, they're not used to being on it. Orthostatic hypotension, they fall over, hit their head. You know, that's probably where it applies to you guys most.
More than you know.
Yours isn't due to medications though, Tyler, I'm not real sure what's wrong with you.
It's not the meds.
I'm so healthy.
Do you have orthostatic hypotension?
He
Yeah, I
fought it a lot in
occasionally
high
stand
school.
up and pass out.
Me too, me too. The only time I ever passed out was because I took off, I was laying down, my brother did something, I took off after him running, I made 3 steps and hit the floor, like blacked out.
My mom asked me to put an ornament up on our Christmas tree a couple years ago. Stood up, put my hands above my head.
It's like, what are you doing?
She didn't try and catch me, she just pulled me away from the Christmas tree.
Yeah, well, don't forget, yeah, don't
Save
forget.
the furniture.
Priority.
Children are replaceable.
Well, yeah.
The best advice I have for that is hydration. That's whenever I notice it. It's when I don't like really
Yeah.
hydrate.
You say that's kind of a sign of dehydration typically.
Yeah, yeah, for sure.
Isn't that something that is tagged also to body structure, tall, thin?
I think so, yeah. I think there's definitely some correlation there.
I don't understand why. I just
Unfortunately.
Yeah.
A lot more miles of veins and arteries in here.
Yeah. Some more distance to cover.
But,
Bigger vessel.
yeah.
It's a long ways to move blood to the head of a giraffe.
That is true.
It's
Yeah.
true.
No offense.
So, anti-aginal drugs.
They don't
So,
land much.
is anybody familiar with the word angina? And that's stuff.
Yeah.
You guys see that? So that's
The word what?
yeah,
Angina.
angina. So like analgesia
Okay,
and
yeah.
angina. Angina is most commonly used in relation to cardiac pain. So that chest pain when you're trying to exert yourself.
So is that commonly mispronounced as angina?
So that's what I've heard more is angina.
Oh.
But there's
I get
analgesics
it.
and
Topical
analgesics or whatever.
Yeah, so all on the same, it's all Latin basis is all it is, so that's, you'll see a lot of those similarities. So yeah, you recognize analgesics, the angina, angina, no, I'm saying it wrong. It's funny, there's a lot of medications we do that with, like mispronounce them wrong for fun, and then next thing you know, that's what you say in front of the doctors.
It becomes the norm.
Yeah. So, okay, drugs affecting the blood. There's one that you guys have on board that does that. Anybody?
Well, aspirin.
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 Yeah, in particular. So what is aspirin?
NSAID.
It's.
It is an NSAID, good.
Yeah, it's
I think I heard it.
Mandy said it.
Yeah, I wouldn't classify it as an anticoagulant, but it's an antiplatelet, which could would decrease coagulation in return. Yeah.
Kind of a blood thinner type of.
Yeah, it would contribute to that as well. So it could increase your bleeding risk, absolutely. It decreases your ability to clot. The antiplatelet effects take about 10 to 14 days to really take effect. But that's the exact reason why people take baby aspirin a day, just to decrease those
Stay on
platelets.
top of it.
Yeah, protect, you know, if you have atherosclerosis, which is narrowing of the arteries, or a stent, you see those patients on that.
I know that we can give 4 baby aspirin pills, but how many milligrams?
325 milligrams.
324.
Well,
Yeah, 81 times 4.
I won't remember that.
I think it comes in a big
Or I
tablet,
can
Comes in at 325,
325.
or you can give 4 that is 325.
Yeah, so what's the, there's one caveat to that though, and so most baby aspirins are enteric coated as well as that 325 milligram tablet. What do you tell your patients to do whenever you give
Chew
them?
it. Chew them.
Yeah, why do you do that?
To get through that.
Get it
Increase absorption.
Increase
Absorption into the bloodstream quicker.
Yeah, because when you chew it, it disintegrates and the surface area is exponentially larger. So it's the exact opposite effect of what we were talking about wanting with the ibuprofen, when we're trying to protect your GI lining.
So
See
we
it
should
first.
chew the ibuprofen.
Don't chew ibuprofen. If you can avoid it.
That's a nice little snack.
But
Here's Amy, kinda eat them like Skittles.
Also though, if you were giving an enteric coated tablet, you would definitely want to chew it for that reason, because otherwise that's a delayed release tablet. And that enteric coating is it is an NSAID just like ibuprofen, is to protect you from the same stuff we're worried about with ibuprofen. And that 325, why it's made like that is because it's used for analgesia and not MIs. So a different indication is why they formulated it that way. And baby aspirin, you're going to take it every day to protect for atherosclerosis and blockages. You want enteric coated because you don't want that constant GI irritation. So that's a protection mechanism. Where MI, where you don't want to deal with that, so we want to chew it up and get it in there fast. In the hospital, I have chewable aspirin. They're still 81 milligrams, and that's what I give the patients. But then to my patient that comes in and uses their baby aspirin every day, I give them the enteric coated tablet. Or if we're going to use it for pain. Yeah, so it just depends on what you're using. But if I have an MI and I only have enteric coated tablets, give it to them, let them chew it up. It'll work. All right. There are lots of other drugs that affect the blood. We talked about Plavix. It's an antiplatelet just like aspirin, kind of like aspirin on steroids a little bit, but basically the same. So those are your antiplatelets. You have your blood thinners, which warfarin, Eliquis, Xarelto, those kind of things. Those are the new novel ones. There's like heparin and Lovenox. Those are all, and all of these drugs that I'm talking about, all 4 of those, all they're doing is when you make a clot, basically it's like a series of dominoes. You push the first domino and it hits the next one until the last one falls, and that's the clot, okay? All those drugs block some part of that domino chain. In the instance of heparin and Lovenox, it's a factor called, actually, all 4 of those except heparin, the Xarelto, Eliquis, Lovenox, heparin, all block factor 10A. So they just take a domino out. So when you hit the first one, the last one doesn't fall. Now, that's a simple way of talking about it. It's not all or nothing. It's not like you take this drug and you're never gonna have a clot. Think about that happening 1,000 times over, and instead of the last domino falling on 1,000 of them, maybe Lovenox binds to 500 of them, and so only 500 dominoes fall at the end instead of 1,000, if that makes sense. And then,
So it doesn't completely wipe out clotting, it's just diminishes
because
it.
then you would bleed to death.
Right.
Coumadin is just a trade name of something.
Coumadin is the trade name of warfarin.
Warfarin.
Yep, and it's a vitamin K antagonist. And so that's why when you eat a bunch of extra vitamin K in your green leafies, you get so much vitamin K that it overwhelms warfarin, okay? Or if you stop eating vitamin K, well now you don't have any, and this antagonist is too
So
low.
it makes the warfarin ineffective then?
In a way, yeah.
Oh, interesting, or less effective.
Yep. And so vitamin K is very important for the clotting cascade as well. And so it's with warfarin, it's fine. With the other drugs, the dosing is consistent enough that you can just say, I'm gonna give you this many milligrams and it's gonna have this much effect on the dominoes. Where warfarin, depending on your diet and what you consume and how much you take and when you take it, can have tons of effect on how many dominoes fall. It makes it much harder to predict, and that's where the INR comes in to make sure we're right at the right therapeutic index might be the right word for that.
Is warfarin used more commonly than those others just because of the expense?
It's very cheap, yeah, except for lab monitoring adds expense and effort. But yeah, it is, The other ones are cheaper, but they're still brand name, the Xarelto and Eliquis, so they're very expensive. Where Lovenox, you can use that as an outpatient, but it's an injection, so that's not fun. And the heparin, same thing. They're both sub-Q injections, so people don't like them, and they're not really necessarily cheap either. So it's cost, but compliance becomes much more important. So obviously with those, anything that thins the blood, your number one risk is bleeding, right? Finding that balance, and so that would present like dark tarry stools, excessive bruising, nosebleeds that won't stop, lacerations that won't stop.
There you go, Tyler.
If they fall and have head trauma, intracranial bleeds are a huge concern. So you always gotta be balancing that. And like aspirin alone, I'm not so worried, but you start getting into the drugs we just talked about, and I'm definitely worried. And then you'll see them on the antiplatelets as well, and then you really gotta start worrying when you start seeing double and triple anticoagulation or antiplatelets.
With our elderly population, we see a ton of blood thinners.
Yeah. So there's not much you guys have on board to prevent that other than controlling the bleeding if at all possible, but.
Although it's something we ask all the time, so.
Yeah, I mean.
That's something that's in our report, is she'll let the ER know.
Are you on blood thinners? Good, yeah, okay. Psychiatric medications, that's a deep topic, guys.
What are you on, Amy?
Nothing, Jimmy.
Oh, there was a.
Yeah.
The third time today, or just the second?
So, I think the best things we can talk about are, I mean, they have weird effects. So a lot of the older antipsychotics will cause all kinds of extrapyramidal side effects, which is like tics and weird movements and shakes, inability with your mouth to like speak right. Like it presents really weird. Like if you see it, you'll be like, something's not right here. So that can be a common side effect, something to keep in mind. A lot of them you can get like a serotonin syndrome, which I'm gonna have to look up even the effects because I've never seen it. But have you seen it before?
Is that the sluggishness that you see in folks sometimes when they're first trying to develop their therapeutic level?
Not really, but a lot of, I don't know, these medication class has so many side effects that like, if you say it, it's probably a potential side effect of at least one or a few of these medications. So that's why it gets really hard. So drowsiness is, it could definitely happen. And then again, the next patient you give it to will have nothing similar happen to them. And so it's really hard. It's a hard drug topic.
In my work, what the worst side effect is, people get tired of trying, to live through finding that therapeutic level and what combination of the drugs are going to be therapeutic and what dosage of the combination of drugs.
Yeah, it is.
And then they just say, oh, to hell with it, and they stop taking the drugs.
100%. It's a trial and error, and it takes weeks on each one to see like real therapy.
They get really frustrated.
Yeah. So like serotonin syndrome would look like agitation, restlessness, confusion, rapid heart rate, high blood pressure, dilated pupils, loss of muscle coordination or twitching muscles, muscle rigidity, heavy sweating, and diarrhea. So a lot of these, go ahead.
Seizures.
Yeah, that for sure. I think that's definitely a possibility. And it's just because like a lot of medications are serotonin and norepinephrine reuptake inhibitors, and so by mechanism they're increasing that level, and then it's common that multiple medications may not do that, but it might potentiate that effect, and then it can get kind of overwhelming. Like I said, I've never seen it, and a lot of people are on these medications, but it's very possible, and it's one of those things like as a clinician that you want to recognize when it happens. So I mean, the problem with it is like what we talked about, benzos, opioids, these medications, like, and however many more, kind of have like the side effect profile whenever you get these toxicities or whatnot, kind of looks a little bit similar. So that's where when you give the Narcan, when you're up to 10 milligrams and it's like, this isn't working, well, we need to consider one of these other things. All right, respiratory system, we have mucolytics. That's this. So lysis, the base word lysis is to break down or destroy. And so mucus is mucus, and so when you're breaking down mucus, it's that simple. You're just thinning mucus, and you can think about like guaifenesin, mucinex, that kind of stuff. Cholinergic antagonist, we talked about that one a little bit. That's a anticholinergic, right? So, in the case of the respiratory system, that's, you know, a lot of inhalers have anticholinergics in them to help dry up that mucus in your chest. It's the same concept as what we talked about with Benadryl for allergies, that anticholinergic effect there. Just think of it in your chest. That's so. Ipratropium, if you guys heard of Duonet, you guys don't do Duonets, right? You just do albuterol. Yeah. Okay, so in the hospital we commonly combine albuterol, which is opening the airway, with ipratropium, which is anticholinergic. So the albuterol opens things up, the ipratropium dries things up, right? Because it's anti-slud, so which is salivation, lacrimation, urination, and defecation, or any secretion really. So it's going to dry things up, we're opening things up, and you should be able to breathe much better. That's the point there. So that's where we use that combination. Sympathomimetics. This one, I want to see what they're referring to. Anybody see this one in the book?
What one?
Sympathomimetics. There we go.
What page?
I think 555. So they're defined as anything that like basically mimics the sympathetic nervous system, which is referring back to the beta blockers, anything that inhibits the adrenergic system, which was so we're talking about sympathomimetic is anything that's vasodilating, like blood pressure medications, or slowing the heart rate, like the beta blockers. So we already covered that pretty well, I feel like. Does anybody have any questions on that? Okay. Do xanthine derivatives? I don't. That's what I want to look up too.
Something about airway constriction.
Where at?
We're looking on 556.
Okay. Oh, here we go.
Xanthines right there at the.
Oh, it's caffeine. Okay. Yeah, I don't use caffeine in the pharmacy necessarily, but I guess. Oh, Dave and I talked about this yesterday. I forgot. So.
I taught. We used a lot of it.
Yeah, I bet. I mean, I feel like you guys have a pretty good idea what caffeine does, probably at this point in our lives. If you don't, let me know what you're doing.
How are you getting through?
It's the route.
Yeah. Okay, so relieves airway constriction by relaxing smooth muscles of the bronchioles, stimulates cardiac muscles to work harder, increases blood flow. Yeah, I don't know if there's much more to be said about that. Okay. All right, the endocrine system. So endocrine is a little complex. It's really complex, actually. And not really well understood in a lot of ways. There's still a lot of research going on. So has a lot to do with like hormone balances and insulin balances and just like the general. Are they off again?
Yeah.
All right. We'll take a second. Let them get back on.
Just put my email in my email.
Wait, you do this.
No,
I don't
'cause-
want to
'cause
do this.
I'm trying to make it so I'm not the only one.
Yeah, I don't want to be responsible for this. Don't put things on me. Yeah, that.
Thanks. So then it's just printed in here.
Don't want to figure out what I'm doing.
Jim, have you taken this test before?
Intensely.
No, not this exact same. This is the first time.
Did you send them a new
Well,
invite?
take
Do you
a
have to
s-
start
we did it
complete
back
new?
when I was in EMTI.
So, on your Zoom, what did you do?
Dr.
I just
Miller
click
taught the class.
participants
We
and
didn't
then
really-
invite.
Okay.
I could
And
do a
then
lot more today, but
since
there's
it's
a
an
lot more to-
education account, I have to
It
admit
seems like
that.
you see more and more.
So that
So once
some random person
When I
comes
first
up to
started, I
classes.
remember when Coumadin was a big
Probably
thing.
good with
And now, I mean, that's, I mean,
Well, I'm gonna
there's
post that.
so much broader.
It's still a big thing, but there's a lot more things now.
Yeah, there are. I mean, there
I'm
really
glad
are.
I have a
I'm just,
YouTube account.
I've learned a lot
That's not my
today.
normal one that I use.
Yeah, not connected to you.
A lot of questions
No,
that
so
I've had,
shading
so
it.
I've seen.
Yeah, that's probably
that
good.
Now I kind of have a better understanding. So thank you.
Good.
Amy's probably the same way.
I don't know why I'm taking this class other than it's good review.
Well, I think a lot of it's new stuff, different stuff than what we had, at
Yeah,
least what
it
I
is
had
good
30
to
years
take. I
ago.
just-
How was that?
Need to have a better attitude
I
about
mean,
it. I like
if
the
it's
learning
not
part of it,
new,
just the reading
it
part of
feels
it,
new.
I don't like.
Yeah.
Cause we didn't remember anything that we.
Yeah, I don't remember, yeah.
I know how to start an ID. You can do that.
I know how, I can. I got the concept, I'll tell you how to do it.
Okay.
Mark's gonna get some pizza.
Oh,
I
yay, you
ordered
did
4
ask me to.
pizzas. Does that sound all right, or should I get 5?
Ask for at least one thin crust, please. Cause Amy's picky.
Did you say 5 pizzas?
Yeah, how's that sound?
Well, we don't have any teenage kids here.
Tyler,
Okay, so Tyler will eat 2 pizzas.
he's still a teenager.
I'm sure we can share 3
For a
little
little while.
You're not,
Alright,
you're a
so-
teenager.
Mature, and
Don't spoil your lunch.
Alright, so back to the endocrine system. We have insulin
Do you have a
preparation.
page on that? I'm not finding it.
I think you're kind of going off.
556.
556, okay, thank
Drugs
you.
drugs affecting the pancreas.
Okay.
Yep, gotcha.
Alright.
No, thank you.
So-
I appreciate the offer.
Insulin, we kind of spoke about that you can't take it orally. It really has to be intravenous or subcutaneous, both work. Sometimes we'll do IV drips on our patients in the hospital for continuous insulin administration. Again, that's just lowering blood glucose in the serum. What it does is it helps your body. Insulin is the tool that your body uses to move glucose from your vasculature into the cells. So it's the transport molecule. And then that lowers your serum blood glucose in effect so that you're not hyperglycemic. Interestingly enough, while it's doing that, it's also using other tools. So just like the sodium potassium pump, in this case, it's like a dextrose and potassium gradient. So when insulin moves glucose into the cell, it then also takes potassium with it, which can make you hypokalemic at the same time. And so you kind of have to watch both together.
Facilitated diffusion? You had a question on that last night.
I think that's right.
Let's put it
Sorry.
this way, it's
Gradient, though,
diffusion.
probably.
Yeah.
if those
It doesn't
functionally
sound
used,
wrong.
then it's facilitated transport, but if they're not, then it's diffusion.
But I feel like glucose was a facilitated, it was a diffusion, not active transport.
Yep, I think you're right. I remember the question.
Yeah, I think it was diffusion, but
Anyway.
I just know I missed it, so I don't wanna miss it again.
So facilitated diffusion is a process where a carrier molecule moves substances in or out of cells from areas of higher to lower concentration. So.
It would go from
It
high
still
to
follows
low.
the same gradient as diffusion.
Yeah.
It's just facilitated by specific proteins or whatever that are moving.
Okay.
So was that right then?
I think.
yeah, I hope they don't ask that on the test, Amy.
I hope they do, cause
But
that's
I
one
think
thing I know.
they asked it on this one, I just can't find it.
No, I agree with Jamie that they asked if what type of process the insulin was, and it was facilitated.
It was facilitated diffusion.
Sorry, don't mean to digress.
Oral hypoglycemic agents, you guys probably carry those, don't you? That's just simple glucose preparation.
Carry
Frosting.
Frosting, you guys are telling me, Mark is telling me that, not the blue stuff though, right?
Not the blue
Yeah,
stuff.
can't use blue anymore. Red's probably on the down low too.
Well, last time we used it,
I
it
prefer black.
kinda made an interesting look.
It was different.
It was
So,
like,
there's glucose tabs, there's glucose drinks,
Peach.
there's,
Yeah.
you know, non-diet soda, don't use diet soda, that's the
Doesn't work,
important
doesn't quite get her done.
It doesn't quite have the same effect.
I'll tell you, it's amazing. You can take somebody with low blood sugar, Coke or Pepsi or something.
Mhm. And that's the one thing I always think about, especially when you're dealing with Narcan, is like, that's probably the first thing to check is blood glucose, because it'd be the number one thing to get missed when you think they're an overdose or something similar like that, or toxicity. But you guys are well aware of that. Hyperglycemic agents. So that's insulin, really, pretty much. That's what you got. You can try to dilute them with plain fluid, but that's not very practical if they're very high. So after that, you're using insulin drips in the combination. So the other thing we should talk about is the IV hypoglycemic agents, because I know you guys are gonna potentially have D5 or D50. I mean
D50 or D10.
D10. So what's the number mean after the D? Or what's the D mean? Do we know what the D means? Dextrose, good. And the number?
Be the concentration.
Concentration, exactly. And so you guys have to do like equations, right? Or calculations?
Yeah, that's coming up tomorrow.
So let's touch on that now while we got that on our topic. So the concentration is in reference to, it's dextrose 50%, and 50% means 50 grams per 100 cc's of fluid. So the volume is always 100 cc's when you're talking about concentrations, and then it's the number of grams in that 100 cc's. So let's see, so D50, it's got 50 grams. So D10 then is how many
10 grams.
10 grams.
Per 100 cc's, right? Yeah, so if I have 50, because the D10 usually comes in a 50 cc syringe. Have you guys ever seen those? It's a blue box. Okay.
So then it would have 25.
Exactly. Yeah. Good. So if I have a 250 cc bag of D10, how many grams of dextrose do I have?
25.
Point.
Oh, see, that's where I'm gonna struggle.
2.5.
Math.
Okay.
2.5. Good. Good.
Let me set up
2.5.
the equation.
Yeah, go ahead if you guys want.
I know, let's get my calculator
you guys-
out.
I can walk you through it too if you guys want to. I don't mind.
Is that what we're doing tomorrow?
Yeah, we'll talk
Okay.
about that
Okay, you
tomorrow.
got it.
Can we talk about the medications that we're allowed to administer?
Yeah.
No.
Do we even know?
That's fine.
It's in this chapter, there's a list.
Yeah.
Near the end, AEMTs are allowed
We'll
to
get there.
administer blank.
Yeah, yeah. So the last thing on this list is herbals. I'm not gonna say too much about that, honestly. If unless the patient requires that they take it, I'm not super, like, now when I talk about herbals, I'm talking about like some of the root extracts and stuff like that you see.
Mhm.
There's not good data on any of it that I mean, there's small studies and whatnot, but it just gets, it's just too,
It'll cure everything.
yeah, it causes a lot of problems too. And so that's kind of what I don't have a lot to say about that.
Eating carrots to help with your glaucoma?
I don't know. I mean, I've heard vitamin A is good, and I'm sure it is, but is it gonna fix it? Yeah, probably not. I don't know. You just have to be careful. Like they do have interactions with real medications. They can potentiate or decrease the effect of medications, and so, and the thing about it is there's not good data, and so can we even really identify those interactions? And that's the hardest part, is we don't even know what we don't know. So that's about it. I mean, I don't know that you can account for it much. There are probably people that are experts in that field that could give you really good answers and say this is a good idea and this is not. But that's unfortunately not me. Okay, so that's it for this handout. I think we've hit all these categories. I know you want to talk about all the meds you guys can give. There's questions in the back. We can talk about those meds. We can peruse through this chapter and hit anything we missed, or you guys have questions on. How do you guys want to go about this? What's the most valuable
The
use of
only
your time?
thing you haven't hit is the right, when
The,
you go to
oh, the
give a
right dosage,
medication.
right,
5 rights.
the 5 rights.
But
Except
there's
they say
actually
10.
now.
Yeah.
But like some of them,
A person writes.
like right assessment, right documentation and reporting,
Yeah,
what,
right
page
patient.
566. There were a lot more than I realized, because we've done the 5, you know, we review those
That
frequently.
Table 1210.
Yeah, so, I've always learned the 5 rights too. I had
Yeah.
not heard the 10, but I mean, this kind of makes sense. So, I mean, do you guys wristband, or how do you guys identify patients? Just by name?
A, B, C.
We trust what they tell us.
Yeah.
We try not to identify them.
And it's just one patient per ambulance at a time, or do you guys double
Not
up?
always,
Not always?
most of the time.
Okay.
A lot
That's
of
our
times, though,
ideal
sometimes we
job.
will have a patient who, you know, we gather up their medications that they're taking, and sometimes there'll be a bottle in there with not their name on it, and you're
Yeah.
like, okay, are they taking it, or?
Can happen for sure.
I'm gonna assume, are like, yeah, I take that one, it's my,
Dan,
Why
we come
so
out of
high?
houses with boxes, I mean.
Oh, I've seen them, I get them in the hospital, whenever you guys bring them to me. I'm the lucky guy that gets to go through those.
Oh, you get to go through those when we bring them in.
He's the one that.
We sit there and we, in one case, we had 3 boxes for one house over here off Ryan Street.
Yeah, it's
Good
crazy.
God.
Yeah. You know, and just cause you get those meds, then we had one come in the other day that had, you know, 5, 6, 7 medications, and not a single one of them were from any newer than like 2017. So it's like, are they compliant? Probably,
Right.
absolutely not,
And
so.
being
What's the
like
best way to
somebody-
dispose of them?
I tell everybody the police department. So, pharmacies can't take back unless they have a set up program with the government. And so almost all police departments that I know of have a drug take back program. Ours in particular, when you walk in the door, there's a bin on the left side right there that looks just like the blue mailboxes on the
Oh,
corner.
yeah?
And you
Oh.
just put things in there and
Did
drop them
not
in.
know that.
Yeah, that's the best place for anybody to get rid of them, cause it doesn't go in landfill, doesn't go in the trash, you don't have to worry about anybody getting a hold of anything.
Yeah, well, that's good to know.
Yeah.
And being somebody who just took care of a terminal patient, some of the medicines, like, I always made sure that any that he wasn't on currently, I'd move so that if the
Yeah.
EMTs came in and gathered, but I don't know that everybody had, cause man, Dad would go on and off medicines, like, so you wouldn't get rid of it, you didn't wanna go take it to dispose of it yet, because next month they may put him back on it, and so, yeah, you
Yeah,
never know.
boxes.
Yeah, I'm sure, and that's, and when there's nobody there, no family there to tell you what they've been on or not, we end up gathering it all up. I mean, we've filled bags and crap with drugs because we find them in the house.
Yeah. They can, yeah, so I mean,
I
as
just
far as.
know
Sometimes we
I
pick them
hid
up off
the
the
other
floor
day.
because they've been spilled.
Yeah, we picked them up off the floor and.
As far as right patient goes, I mean, you guys have to work out your system. Probably most of the time you're never dealing with more than 1 or 2 in the back of the ambulance at a time, and so that probably makes things a little easier. In the hospital, we use a wristbanding system so that, you know, and we always verify by like 2 identifiers. So your patient Jane Doe and your date of birth is February 2nd of 44 or whatever. And that is usually pretty good. It's pretty hard to mess up at
But,
that point.
and really, we don't administer a lot.
Right, so that also decreases your risk.
I think that,
Yeah, I think you guys are pretty low risk on that regard. So right medication, I mean, that one is important. You know, again, you guys don't administer a lot, so hopefully it's pretty easy to be
right, so
familiar
the
with what you
aspirin,
do have.
glucose,
You know,
As we get a few more, it's just
we'll need to be
making
better
sure
about
that-
it, no.
yeah.
Most
You know,
of the time when we, at least most of the time when I think about the 5 rights is, like, if I'm administering an inhaler, making sure that it's that person's, it's
Yeah.
the right one, it's not expired, that kind of stuff.
Assistant.
Assisting, yeah.
Sure.
Prescribed EpiPens. I know we also, I've never had the opportunity to use either of those, but yeah.
just looking at the list that I have here on my paper, and this may not be everything, the number 1 risk of mistake I see for you guys is gonna be your, if you guys carry a D10 or a D5 and your LR, putting the wrong fluid up. Which the risk of adverse outcome is fairly low with that, unless you meant to hang D10 and hung LR. Then, you know, you got the hypoglycemic patient that's not gonna get the benefit, but for the average person that's not hypoglycemic, your adverse risk is low, but it is in that area, so.
So we would set up a D10 or D5 similar than we would through IV, so it's intravenously.
Yeah, and the only time we're gonna probably run into D5, we used to carry it in the ambulance all the time. Every so often, they'll use a transfer rig, and every so often, the transfer people will lay a D5 in there. So that's typically what they use for a lot of medication administration. They'll have an extra bag of D5, and they'll forget to leave it in there.
Okay.
So you always wanna look at the bag and see what it is.
Yeah, other
But
than that.
normally we would not carry that.
Normally we don't. We used to, but we don't anymore. Typically, we just didn't find we had a use for it. I mean,
Cause its shelf life isn't very long, is it, I wouldn't think?
no, D5's the same as.
Is it?
I mean,
Oh,
yeah,
okay.
it's
A
not
year,
that
2
bad.
years maybe.
We just didn't, I mean, it was either normal saline or LR. Typically, we just kinda got rid of normal saline, went down just to LR. That's typically what we use.
And bags of fluid just look remarkably similar, you know?
They all look the same.
Yeah, as wired. the rest of what I'm looking at that you guys have is probably pretty hard to mix up. So right medication should be pretty easy for you guys. Right dose, you know, that's where you gotta be a little more careful, making sure, like when you guys run, are you guys running nitro IV or just oral nitro?
Just oral nitro, sublingual.
Much easier, good. Okay. Epinephrine, for epinephrine, you guys using vials or auto injectors?
Auto injectors so far. I think the move may be back to,
Really?
well, I don't know, we're gonna talk, I guess something.
See, that's where it makes me nervous, cause
Just-
that's where you screw up, is when you're in control of how much, where the auto injector kinda
Yeah,
keeps
it's
you.
just been the cost, I think, on the auto
Yeah.
injectors is relatively.
The vials are a 1 milligram per 1 cc vial, and you just draw 0.3 cc's.
So I can figure
Do
that
that.
out. And it would
Yeah.
be the same, like not, you wouldn't have to figure out body weight of the patient.
Child's what? 0.15.
Yeah, half. That'd be the only thing. I think other than that, it's pretty much standardized, if I remember right. I'm going off memory, but.
Yeah.
So if we were to do that, would it be how would we administer?
Intramuscular.
Intramuscular.
I am.
So the same, just using a needle and a syringe instead of the auto injector. Okay.
That was one of the things the state requested on that we talked. You know, I think you can still go ahead and use the auto injector for whatever reason they wanted the IM also.
Okay.
Do we have?
Which might indicate you're
I actually think the syringe is more effective because
Why-
those
why
auto
it's just
injectors
a syringe
fail.
I don't
Or
know.
you do
To be
it and
honest
you
with you, Dan.
pull it back where.
Too fast.
Instead of
Where
letting
it's a
it.
syringe, you actually
Pens
know
isn't
they
going
got
to date
their
so often.
dose.
Yeah, that's a good point.
But if you're trained right in the epi
Right.
I
pens,
mean, if you
they're
know not
pretty,
to.
you just have to.
Whereas the vials have a lot
Know what
longer
you're doing.
shelf life.
Yeah, I mean, I don't know if they have any longer shelf life, they're just cheaper. You don't have the injector component of it.
Or you're not paying the brand name for it.
Well, they kind of lowered the price on it, but I heard now it may go back up, I don't know.
Yeah, they're still not cheap, but I don't remember off the top
You
of my head.
reversed the legislation already on it.
Yeah, that's what I read, yeah.
So right route, that should be, I don't see much that's gonna give you guys a challenge on that. And like the nitro tabs, the Narcan, aspirin, you know, D50, most of these things are kind of, if not in the unit of dose, pretty close, so it's gonna be hard to like.
Mess it up.
Yeah, honestly, if anything, you're probably not gonna give enough, like an only thing, like an aspirin, like, you need to get 4 tablets, which, that's one thing I would also, as a piece of advice, things are usually manufactured in the most practical way, and so if you find yourself, I need 10 vials of this, like something's probably wrong. Like, that's a good time to question yourself, cause like, epi, you should never need more than one.
May need to
like-
move a decimal.
Yeah, like, that's a good like tip that like, you know, and most of the times if I was given 4 tabs of something, that's the time where I'd stop and be like, is this the right dose? But with aspirin, we're familiar enough that, you know, that can be comfortable. But just a tip. Right time, I think that's pretty straightforward for you guys. Documentation and reporting, I mean, that's always good. You're gonna wanna let the ER physician know what you've given them so they don't repeat what you've already done. But aside from that, you'll just have to work out a system. Assessment, you know, do your blood glucose checks with dextrose or with anything. You obviously wanna know blood glucose. That's probably one of your guys' first checkoffs, right?
Mhm.
Yeah.
We do that.
So good. Right to refuse, of course, a patient has the right to refuse any medication, at least if they're conscious.
Yep. I wanna refuse that IO.
No problem.
Nope.
He's out, Amy.
Yeah, I mean, you just have to respect their autonomy like the book says. You can counsel them, you know, if it's a life or death situation, like, or I really think it'll be to the patient's benefit, I'd be like, I acknowledge that, like, you absolutely have the right to refuse that medication.
We
and
did
that's
have a
sometimes-
guy that was in the middle of a heart issue and we were clear out at Grass Creek and he didn't all out refuse the nitro, but he
Yeah.
didn't wanna take it if he didn't have to, cause
Sure.
he'd taken it before and didn't like the side effects to it.
Yeah.
And so we monitored him until, you know, and said if it gets, you know, worse
Yeah.
or whatever, but.
That's exactly what I would do too. I would, you acknowledge it, ask them why don't you, like, are you afraid of something? Do you have a bad experience? Do you have an allergy? Which you should always check allergies. That should have been one of the earlier things on here. I
He
can't
just
believe-
didn't want the headache.
Yeah, yeah, and I
That's
mean,
fair.
yeah, you can counsel them on it and like explain to them, you know, if it's aspirin, like, you know, like this could really increase your chances of survival. The risk of you having any complications is minimal. It's totally your choice. It'd be my recommendation that you take it. You know, you can kind of guide them in the right direction. Definitely, you can't force them, but use your better judgment. I mean, if it's that's about all you
Pin
can
their
do.
arms down and say, "Get ready."
You can get mom, a little mom on
I might be able to pull that off.
Mean school teacher.
Yep.
All right, so, right evaluation, we've kind of hit that, I think, multiple times on, you know, just keeping all differential diagnoses in mind, that don't get tunnel vision on what you think is going on. Keep your mind open. And then right patient education, you know, I think you guys can probably all get that, like just telling them what you're doing and why you're doing it and how it's gonna benefit them is important to keeping them comfortable and happy and understanding and not scared.
If it doesn't go that way, then we still work through it.
Yeah, yeah. Any questions on that? Any comments? Okay. All right. All right, so anything else do we want to hit anything else in the chapter?
Well, would you want to go through the medications?
Yeah,
Yep.
Just give us things that you would see as potential issues we need to be aware of, or something that.
Yeah, so I'm starting on page 570, is that what you guys have?
Yep.
Okay, so for albuterol, you guys are doing MDIs, or, well, what's MDI stand for?
Metered dosed inhaler.
Perfect, good. And that's what you guys carry, or do you guys carry nebulizers?
We don't carry any more, we used to. I think we'll probably have, well, we do have a meter dosed
So
inhaler.
I think we have an inhaler.
Yeah, we do
Yeah.
have the inhaler still. We used to have the ampules that we would break them and put them into the
Nebulizer.
nebulizer deal and give a nebulizer treatment to ambulance. We lost the ability to do that.
I have
I don't
never
know, I
done
think we
that.
might go back to that now. We'd have the option after finishing this.
So keep in mind with nebulizers, in COVID, nebulizers aerosolize.
Yeah.
And so the aerosolize COVID. If you're in an ambulance, it's not a good place to be. You have your vaccination.
Okay, we're not gonna be doing that anymore.
You can get aerosol containing nebulizer mask filter things now. Our respiratory department has it. But when COVID was new, we stopped using nebulizers in anybody that had any respiratory symptoms.
Interesting. Would not have thought of that.
What is the, what would be the dose difference, or is there a dose difference in a meter dosed inhaler and a nebulizer?
It's pretty close to the same. 2.5 milligrams is a standard nebulizer. The meter dose inhaler, it's pretty close, but I don't remember what the exact number is. I can tell you here quick.
That's
You
what
have
I
a
know.
nebulizer too, though, that you use when you're little.
Oh, I haven't used that.
Well, the reason I was thinking that is because an inhaler is just like 2 shots, and it's not a 15-minute deal where
Right, takes forever.
all of our transport, you know, unless we're out of town, less than 5 minutes in town, so I just don't see how that would be beneficial.
So an MDI is 90 micrograms times 2, where the nebulizer packet's anywhere from like 0.63 milligrams to 2.5 milligrams, depending on which one you get. But also being aerosolized, like a lot of that gets out.
Right.
And so I'm not sure like how much, I assume they consider it somewhat comparable, but that's left open to interpretation, I guess. All right, so with the albuterol, like, let's see. So good beta 2 agonist. I told you guys strong thing here. Okay, so I have to correct myself, guys, and I'm sorry. Albuterol is a beta 2 agonist in the smooth muscle of the lungs, causing dilation, which is why it also, I assume, is causing increased heart rate, where and I think that could also contribute to why you would want a beta 1 selective beta blocker in the heart, is because it would not have antagonistic effects in the lungs causing constriction and like potentially like COPD or asthma or something like that. So sorry about that. My apologies. I knew it causes relaxation, but I just had my mechanism backwards. So the biggest concern though is just their heart rate, I think, and making sure they're not outrageously tachycardic, because you don't want to speed that up. And it talks about tachycardia with digoxin and not combining these two together. That's probably about all I have to say about that. Just, you know, it's an inhaler. Pretty simple. If it's an MDA, you want to make sure you shake it up first. Don't just, because it will settle out. Oh, we didn't talk about pregnancy categories. I just realized.
Oh, yeah.
So
I was gonna ask about that.
This book references categories A, B, C, D, and X.
Yeah.
Category X is like, just don't ever do it. D is like, you better have a really good reason to do it. There's probably some potential for some adverse effects here, but if you really, really need it, then okay. I feel like C is like, we're on the fence, it's a 50-50 shot. B is like, it's probably okay, small chance maybe in some animal study somewhere that they saw something that made them think, not sure, we should just watch this. And A is, it's fine. And I think, when I was in school, that's what I learned too. I'm pretty sure since then they've updated to a new schematic for classifying those, but every drug database I use still uses those letter codes. So if you see something different, it's the, I don't remember even what they changed to, maybe like some color coding of sorts, but I've not seen anybody use it yet. But if you see something, just something to keep in mind, it may be changing. So aspirin is an antiplatelet, but it's also an NSAID, okay? Where I don't really classify the other NSAIDs as much as antiplatelets, while they do have probably some minor effect. There's a patient population that we really probably shouldn't use aspirin in. Does anybody know what that is?
Children.
Yeah. Why?
Rise
syndrome.
syndrome.
Because what's the age cutoff on that? It's either 16 or 18.
I was thinking it was older, yeah.
What was the reason?
Rise syndrome. It's like an allergy that's common in children. Or with salicylate allergies, don't forget that.
Say that again?
Salicylate allergies.
16.
16? Thank you.
I didn't realize it was contraindicated. No, I.
Rise syndrome.
R-H, or R-E-Y-E.
R-E-Y-E, apostrophe S.
Yeah. So they don't. My grandma gave me aspirin all the time when I was a kid. But
That
here's a
explains
baby
it.
aspirin.
I took it too.
I've taken it in my asthma.
Yeah.
So, I mean, and right, like there isn't even an age indication on here that I can see. Oh, not recommended in pediatrics. So, I mean, just know that that's a risk. I would probably avoid it. Hopefully you won't be encountering any pediatric MIs.
It's category
Yeah.
D as far as pregnancy goes.
Yeah.
Something to be asking.
Yeah.
Yeah, and just keep in mind, it does say like, regardless, if you're, you know, if you don't have any other reasons that in ACS, you should still give the dose, if there's no reason not to. It's a risk versus benefit thing, right? Like, so if you give a category D medication to mom, there's a small chance that she could have some adverse effects, but what happens if mom dies from a coronary event? Like, baby doesn't have a chance anyways, and so.
Right.
That's been the same like thought process with the COVID vaccine too, is that there's no reason to believe right now that there's any adverse effects to pregnancy or lactation, but you know, we don't have long-term data either, but it's the same concept of the risk to mom and baby if mom gets really sick with COVID. So very similar scenarios. You know, do you guys have contact with physicians or the ER sometimes, or usually when you're on the road with the patient?
We can. We always talk to the ER.
Yeah. I mean,
medical advisement.
We always, if we've
that's
got a
my
question.
recommendation. If you guys have like something like that, you're in that situation with a pregnant mom, and it might be worth just running it by the physician real quick.
I think almost always we wanna do that.
Yeah. Yeah. Oh, do you guys, is that standard?
Yeah, it would have to be something pretty unusual.
What would we, yeah, I don't know
out of
if
our-
we usually administer any drugs other than oxygen.
But anything
But,
we
I
have
mean,
there
I
is
would-
aspirin.
you-
Anything that, I can remember a patient we couldn't
Well,
get out of
that's
a
true.
room that we called and asked for advice on for somebody
I
to
wasn't
come.
on that call.
Yeah.
I remember it.
But, yeah, I mean, we can always get a hold of the hospital. The nurse may or may not have an answer for us. And sometimes the docs are there too. You just never know. We've had a doc jump in with us out on Black Mountain Road a
Yep.
couple times.
And we had all our ducks in a row. By the time we got him, we had everything taken care
Yep.
of. 2 IVs started.
Yeah.
We had it going.
Have you ever done a jugular IV?
No,
No.
no.
I don't think we're
I feel like I've seen one done in the
authorized
ER.
by our medical director to do a.
I've tried a pedal one once and failed.
Foot IV?
Mark, yeah.
I have better veins in my feet than I do in my arms.
Then we'll practice that tomorrow.
I'll give
Thanks
you
for
my
volunteering.
hands before my feet.
Thanks for playing.
I'm gonna also.
Tyler, go back to college and say, what were you doing
Why
over
are
the
you-
weekend?
Why do you have track marks all over your feet? That's so weird.
You do like 2 IVs on each side and you go back to school. You do all these things.
I got poked
Yeah.
by
Good mom.
Alright,
No.
so let's go on here to dextrose. We talked about the D5, or the D5, D10, D50 already. That can be given either IV or orally, actually. That D50, you could drink it if you wanted to. Just a tip. Should work
Yeah,
fast.
as long as they have a gag reflex.
Epinephrine, good for anaphylaxis. That's probably about all you guys would use it for in allergic reaction to asthma. Dosing is really critical. You don't want to, you guys shouldn't be given epinephrine IV. It should really only be IM or subcutaneous, and the IM route is preferred for better absorption over subcutaneous, where absorption is a little slower, a little less predictable. So I'd only give it IM. The big risk here, if you guys have, alright, so you guys will have IV access if you're on flus. If you give the 1 to 1,000 concentration that you guys have in those, not, I mean, the injector risk is low, but if you guys go to the purple cap vials, the 1 ml vial, if you give that IV, you can cause a MI. Okay? The concentration's too great. What we use in IV in the ER is diluted to 1/10 that concentration. It's 1 milligram in 10 cc's. But the 1 milligram in 1 cc's can cause a cardiac event. So you want to make sure you're only giving that IM and never IV. Okay, that's really, really important.
So when they're giving them epi, when we're coding them in the hospital and they give it IV, it's
Yeah, it's that brown
Much
box if
lower.
you've seen it. It's the same amount of medication, but in 10 times the volume. It's in 10 cc's, and then you can push that. But the thing is, you don't want to inject 10 cc's into somebody's leg IM, right? Because your max volume for IM administration
that
should
would not be good.
Really, like 1 cc is ideal, but 2 cc's max in one location is as much as you want to do on anybody. So your 0.3 per 0.3 mils is fine to inject IM. So that's why it's got to be more concentrated, is because of the injection site, because where IV has to be more diluted because of the cardiac effects if you give too concentrated a solution. So it works fast. Don't know that there's.
No, that's interesting. It's a category C also.
See that.
Yeah.
For pregnancy.
That's another one, kind of very similar. Like if somebody's bad enough that they need epinephrine, you're probably gonna have to just ignore that more than likely and take your chances. Glucagon, is kind of a cool drug. So another IM injection for hypoglycemia, good for when you have that unconscious patient and you don't have IV access. That's the niche here, is that it's something you can get into them fast whenever you do have almost no other option. So, category B. So they talk down here at the bottom of special considerations about using it in conjunction with the D50. I mean, I think that's important. I'm probably going to use D50 first if it's possible. I mean, but don't delay. I mean, the cool thing about this is you don't have to delay to establish IV access in somebody if you have that hypoglycemic patient, because obviously the hypoglycemia is much more deadly than hyperglycemia in the short term. Contraindications is hyperglycemia, which hopefully you don't have to worry about if you check the glucose, and hypersensitivity, which if you're using it, they're probably not going to be in a condition to tell you that they have hypersensitivity to glucagon, so it's a chance you got to take. I mean, the alternative is that they die from hypoglycemia, so I guess it's all right.
I know it's not in this chapter, but in chapter 13 they talked about rectal administration of D50.
Yeah, we're not doing that.
Dan says I'm out.
Come on, Dan.
Good job.
You gotta draw the line somewhere. That's where it is.
Fair enough. So,
Well, I could, I mean, having had some patients that were extremely combative, I mean, you're not gonna get that done either. I hate to say it.
holy cow. So,
I don't think that's gonna lessen your combativity.
Yeah, but I read that and I was like, wow, that's.
I
Well, in my
overhearing the
help,
route.
like, okay, we got two choices, we can do it this way or this way. They might settle down just a little bit, you're like, all right, I'm in. Hit it in my arm, that's fine. Arm's good.
But the glucagon is, that's IM.
yeah, it's pretty simple. I think it's I'm trying to think. I can't remember. I haven't used it, but it might be it's a small vial, and I want to say it might be a powder. You may have to dilute it first.
The only ones the only time I've ever seen it used, we had a patient who had a injector pen of glucagon as a diabetic.
It is. Well,
And
okay.
that was over in Easter Mop, and I assisted him with the pen. At the time, we weren't probably supposed to assist with the glucagon pen, but he stuck himself with it. It was amazing how quickly he came back.
Yeah. And so if you get the vials, they do have to be diluted. They're like a 2 cc vial, but they come with a diluent. So you just have to draw that up and then squirt it into the vial, swirl it, draw it up.
But they used to come in a tab, kinda like I don't know, they were probably about a quarter size, but probably twice as thick.
There's definitely glucose tabs that are that I've seen that fit the description of what you're talking about.
Maybe that's what and that could be what it was.
Yeah.
I was thinking that it was like prescription level, but.
That might be. All right, so naloxone here, we got our opioid antagonist. Good for those opioid overdoses. So competitive inhibition, this is a good concept. I kind of maybe misspoke earlier when I was talking about it combining to the med itself. It more so competes for that receptor site, so it beats the opioid there and then occupies that receptor so that the medication can't do anything and is then metabolized and excreted before having a medical effect. Yeah, so just, I guess the thing to keep in mind of this, if you check their blood glucose, it's normal, you have reason to believe they've been using opioids and you give it to them. Opioid withdrawals can be pretty unpleasant. So, I mean, you want to get them back because they're going to, that's the overall goal, is to keep them from dying and then get them to some level of self-sustaining consciousness. But then might slow down at that point, because if you keep going and they're long-term users, the withdrawals can be ugly. So, and they'll be miserable. So at that point, you just probably, once they're stable, get them to the ER and let them deal with them.
Yeah, so you come on a scene and you find a syringe laying there next to somebody who's passed out. Well,
yeah,
the syringe could have been heroin. It could have been somebody took their insulin and now they've got a
you don't know.
severe blood sugar deficiency.
Do you guys have, so you guys don't have Narcan right now, is that correct?
No.
Okay.
We should, we're supposed to, but we have not started carrying it yet.
So it comes in two forms that I'm familiar with. The first one's a 0.4 cc, 0.4 milligram vial. I think it's 1 cc. And the other one is a syringe deal, and so it's like a carb eject. It's like a glass container with a threaded end, and then there's a plastic deal that has a cap needle, and it's like a hollow tube. And so you screw that glass carb eject into that, and whenever you're ready, you can pop the plastic cap off, and there's a needle, and then you can use it just like an injector at that point. And that's a 2 milligram dose. So the standard dose is 0.4 to 2 milligrams. Most people probably, if they're really in an overdose situation, 0.4 milligrams is probably at the low end of what you need. The 2 milligram syringe is probably, that's usually what people carry, because you don't need another syringe needle ready to go. You just use that injector, and that's pretty standard, 1 to 2 milligrams every few minutes. I think it's, is it 5?
Yeah.
Repeated 5-minute intervals for a total dose of 10 milligrams. So
We had talked about using the nasal.
yeah. And I think the dose is the same on that, if I recall. It's just different route, you know, you just atomize it instead of injecting it. So that'd be fine. I've seen people take 4, 6, 8 milligrams of Narcan to start coming around, so it's not uncommon, but yeah, you should start getting some effect with a few milligrams. Nitroglycerin, so we're doing the oral tabs here, so it's just relaxing the smooth muscle, and primarily nitro is going to work on the veins more so than the arteries. The good thing about that is when you think about, well, 2 things. The heart's affected on both ends of the vasculature. It's like interstates are your veins coming in and your arteries going out. If the arteries or the veins coming in are too contracted, we can. We'll be right back after these commercials.
Commercials are usually entertaining.
Well, we do have pizza coming. I don't know how quickly it's gonna get here. Mark said he was gonna bring it, so
Hell yeah.
check's in the mail.
I love
We want to talk bad about
So was
especially.
10 Sleep planning on coming over tomorrow for IVs, or are they just gonna do their thing there?
They're gonna do it there. They've already, the one member already is doing it,
Yeah,
so.
okay.
And then Becky, of course, is certified, and then.
She's already an 8, right?
Yeah, and then, the other gal, I think, is gonna do it there.
You two, Jim and Mother, dearest. I remember the 2 of you talking about doing IVs on yourself and competing against each other. I'm gonna do it. Join the club.
How many beers was that?
None. We're just competitive.
And
I think Natalie started it.
I'm also competitive.
Remember that?
Really?
And she
And
said she
if
did
you
it, so
haven't
we're like,
noticed-
well, you can do it, I'm doing it.
So I'm gonna do it.
Do you not remember that? You started an idea?
I remember doing it on myself, you laughing while I was doing it.
I know, but I also am competitive enough that if you're doing it, I'll do it,
Whatever you can do, I can do.
so.
that.
Yeah.
Yeah.
The nurses
It was
at the
definitely more
hospital-
challenging than I
nurses at the
anticipated.
hospital
Oh my, I
gave
got good veins, I
me
can
some,
do
I
this.
don't know.
One-handed was a little
We
bit
can go.
tricky.
Okay.
All right, so nitro, like I was saying, works a little bit more on the arteries or the veins than the arteries. And then what I was saying is like the effect that it can have on the heart is because if your veins are too constricted coming into the heart, that's a lot more pressure, just like a garden hose, right? The small hose, more pressure. And so that can, it's like the preload on the heart is more because it's all trying to push in. And then the same with the arteries. If you have a constricted artery, it's trying to force that blood out a little hole as opposed to a larger hole. So nitro works on both sides, which is why it helps the heart, because it just opens those up, which makes it easier to move that blood. But primarily more on the venous side of the system is where it has its most effect. So kind of similar to Narcan in a way, 0.4 milligrams sublingual, so they'll just put it under their tongue and let it dissolve, and you can do that every 5 minutes for a max of 3 doses. Contraindications, it will decrease your blood pressure, so you want to have solid blood pressure, no hypotension. Hypovolemia contributes to that. Intracranial bleeding or head injury, that's kind of important. you gotta be careful with like, I don't know, I might say this actually, let's see. Well, it talks about, on the head injury thing, like stroke patients as well, you gotta be really careful with, because decreasing their blood pressure can decrease their perfusion too greatly and cause problems. So just something to keep in mind if you would see someone that you can't quite identify the etiology of what's going on.
So if we suspect a stroke, it's probably
I would definitely.
contraindicated.
Yeah, stroke, head injury, anything head, I would consult a physician before you do that. Yeah, it's just best practice for sure. And then it talks about the sildenafil, vardenafil, and tadalafil, which are they can be used for pulmonary hypertension, but they can also be used for erectile dysfunction. They're vasodilators, and so obviously that's that potentiated synergistic effect that you could see it cause too much vasodilation. Category C, it's been used safely during pregnancy. Yeah, I mean, that's pretty straightforward. Nitro paste is just topical nitro. I think all the same stuff applies. If you're trying to treat that chest pain. And I think everything else should probably be pretty much the same. Any questions?
So, well, route, transdermal, so like is there a specific part of their skin that you would wanna probably go with on that?
Seen it on the forearm, I
Forearm?
think is what I've seen in the past, yeah.
Okay, and it's typically, now what's the difference between a paste and a gel?
So it's the water content typically. So paste is a little drier, where gel is like really, I don't know, it'll stay wet longer, where paste is more likely to like dry and absorb it.
Does one absorb faster than the other?
I would say paste for sure. A gel is more like a barrier, kind of in a way. Like it's not made to necessarily absorb. So like, when you think about like lotion is very watery, and so it'll absorb fast, but it doesn't have as good moisture content. And then you get into like creams are a little more on the oily side, and so they might leave residue. They may not absorb as fast, but they're going to be like more moisturizing, I guess, in a way. And then you get into the gels, which are maybe the most protective, but they aren't going to absorb. They're going to leave oily residues. And so it's just this scale of like the water content and how hydro or lipophilic they are, and it kind of affects how they perform. And so like somebody that has to put nitro paste on, you don't want them walking around with like this big ooey gooey gel spot on their arm. And so that's why a paste would be better, because you could put it on and it's going to dry and maybe absorb, and just a little more practical for the application, I guess. Nitrous oxide, that one, guys, I don't deal with, so that'd be our respiratory therapy team that does that there, and maybe some of the nurses would have, and Chris might actually know, if you guys wanna pick his brain about it. I bet Chris would know.
We actually thought about asking the dentist to come put it.
Okay.
Because they use it quite often in the dental office.
And we use it in the hospital, and I know Chris was involved in that. I don't get involved because it comes from cardiopulmonary to whoever's using it, so it skips me.
Well, what are the chances of us carrying that?
Slim to none.
Okay.
What are the possibilities of it being on the test coming up?
Test, right. I gotta remember that I probably should
Relatively
plan on
high.
passing these tests, huh?
We can use it for dual purposes. You can get to the hospital really fast, and everybody can breathe it in and not be scared of brain striping.
So, oral glucose, we kind of touched on this a little bit. The reasons you wouldn't want to use it are just because they're unconscious, they're nausea vomiting, they can't hold it down, etc. That's where your glucagon, maybe IV dextrose become a little more practical. There's not really any other reason not to use it. You can't really hardly hurt anybody with it. I mean, if they're hyperglycemic, they don't need it, that's for sure, but odds are if they're conscious enough to take it, that, you know, it's pretty low, much no risk at all.
Help me remember what buccal means. The route.
It said cheek, huh?
Oh, buccal.
Cheek. Okay.
Yeah, that's where you like hold it, like in the cut of your mouth, like a cow does with their food. It'll just dissolve there, just like It's very similar to subcutaneous, sublingual, I'm sorry, yeah, thank you. Oxygen,
Amy.
oxygen again is not really my forte. Probably can't help you with that much more than you guys already know.
No problem.
Lactated ringers, so it's just a crystalloid. It's a combination of different electrolytes and sugars. They have a contraindication here of heart failure or renal failure, and my best guess on that is that with renal failure, sometimes like electrolytes in particular, your kidneys filter water and move water by using sodium and potassium back and forth. So are you guys familiar with like isotonicity at all?
We're just learning about this.
Okay, so like if you have a gradient, if you have a bag that's permeable to water but not permeable to salt, and or let's say a container and it's divided in half by this semi-permeable layer to water only, not salt. You pour a bunch of salt on one side. The water, if it's even at first and you pour salt, is gonna do this. Because it's gonna try to reach an equilibrium between the two, isotonicity. And so you can consider the side with more salt to be hypertonic and the side with less to be hypotonic. The same thing happens in your bloodstream. So like whenever you become like, let's see, like your blood volume is gonna follow. It's the best example for this. So what I'm thinking here is the reason they say don't use it in heart or kidney failure is because whenever you're more or less, your kidneys are you're filtering these electrolytes, and if your kidneys aren't working well, maybe they're not filtering these electrolytes very well, and so you can get buildups basically, and so maybe you're at more risk of hyperkalemia, hypernatremia, which is high potassium, high sodium, those sorts of things, because this solution does have some of that in it. As where normal saline that just has sodium has some concentration, depending on if you pick 0.9 or 0.45%. Might be a better choice. I think that's where they're going with it, because I looked it up actually in my database and it doesn't list that as a contraindication.
I know we use it for everything. I mean,
yeah.
we hang it, but we're not running large volumes into someone who's having a heart attack. We're just going TKO.
Just for other
So a
medication.
hospital can go ahead and use it to administer
Yeah, I think that.
IV medication.
I don't see anything wrong with that. I mean, yeah. You gotta be a little careful. I mean, hypernatremia can be a little tricky because it can cause like all kinds of like intracranial hemorrhage basically if it's too high, because that water wants to follow that salt. So when you get too much salt, the water's following it. Next thing you know, you end up with a lot of fluid volume. So in your head, that can be really bad. But I feel like the TKO is not gonna. By the time you get to the hospital, it's fine.
The only time we would run it, you know, obviously if we want to give a bolus when someone's, you know, seriously got low blood pressure after we suspect internal injuries.
Right.
It's about the only time we run
that's
anything
reasonable.
larger than TKO.
Yeah, and we don't even do that like we used to do as much. I think we try to keep it a little more reasonable.
5% dextrose, that's just, 5 grams per 100 cc's. No, should not be used as food. Okay, so you shouldn't use 5% dextrose in hypovolemia, and that's because when you're hypovolemic, you don't have enough plasma volume in essence, and your blood pressure starts falling, right? And so when you give dextrose doesn't perform the same as the salt in the scenario I gave you. And so that water is essentially 100% free water to go chase that gradient. And so when you start diluting, if you consider the extracellular space outside of your veins and the veins to be the same concentration, okay? So they're right here as far as salt concentration goes. When you start putting in a solution like plain dextrose that doesn't have any salt in it, you start diluting this side, so it's less salt. Whenever that happens, it wants to make the salt concentration equal, and so all that fluid that you're putting in just goes right into the extracellular space, chasing that salt gradient, and so you're not helping their plasma volume.
Okay.
They're helping their overall hydration status, but their blood pressure will not get the same effect as a isotonic solution like normal saline.
Okay.
Does that make sense?
Yep.
Okay. So lactated ringers is I'm questioning myself. It's 97%. I think it's 97%.
You're good.
Am I good?
Yeah, you're good. I was just letting Brendan back in.
Man, I think lactated ringers performs 97% like sodium chloride, normal saline. And then, so it'd be like 3% free water. And that would do the same as the dextrose, but 3% is marginal. It's not that big of a deal. And I'm 99% sure that's right. So like sodium chloride, 0.9% normal saline is going to go into those veins, and it's going to be isotonic to both the extracellular space and the vasculature. And so 100% of that fluid can stay in your veins and increase your vasculature volume to support your blood pressure in that acute state, and it doesn't leave where you don't need it in your cells. But the salt gradient is still the same because it's isotonic to your blood fluid. Now, have you guys ever seen, like, you guys probably don't carry this, but half normal saline, there's 0.45% sodium chloride?
Never seen it.
Okay. So it's half the concentration of salt. So half of that volume could be the same and stay in the vasculature, the other half would leave. And it's just a balancing act of where you want that fluid is which fluid you pick for that patient. So the important thing for you guys is if you have that trauma that's internal bleeding, dextrose is not a good choice.
Okay.
All right. So I kind of hit dextrose and a little bit of sodium chloride too. All right, so what's isotonic? Do you guys pick that up?
Equal.
Equal.
So the
Equal concentration.
so it's gonna kind of stay where it is.
Yep, good. And hypertonic?
Higher concentration.
Higher
Right.
concentration.
And whatever's relative, and hypotonic is the opposite.
Lower.
Good, good. All right. Those are useful concepts to just keep in mind, especially with that dextrose. That's, let's see. So they're talking about, this is helpful, on the sodium chloride, they say 0.9% sodium chloride should not be considered in patients with heart failure because circulatory overload can be easily caused. And that's because 100% of that fluid staying in the vasculature, and the heart has to move all of that, as opposed to if you give them a half normal or a D5, those ones, some of the fluid's gonna leave and go into the extracellular space, still hydrating them, but the heart doesn't have to move that whole load, only for a little bit, and then it'll leave over time. So I think that's where they're going with that. Now that said, I think that I would consider that a relative contraindication. All right, anything else you guys wanna go over? Do you guys wanna do the questions together?
At the end of the.
Yeah, there's an assessment on page 584.
Sure, let's take a shot at it.
Okay. All right.
What's worse gonna happen?
We got pizza too when you're ready.
Awesome. Okay. Well, let's knock these questions out. Which of the following is not an indication for the use of nitroglycerin? Angina pectoris, pulmonary edema, hypertension, or commotio cordis?
I went with D.
So,
That was a guess.
I feel like it's not related to blood.
Nitroglycerin.
he's right. He's
B?
right. Yep.
B.
So,
Yes, pulmonary edema.
right. Pulmonary edema is just fluid in the lungs. Nitroglycerin being a vasodilatory agent will not help move that fluid off the lungs. It will decrease your blood pressure. It will relieve the heart pain. And commotio cordis is it's related to cardiac pain or issues in some regard. I don't remember the exact definition, but it is cardiac related. That's just where they're trying to trick you with a big word.
Yes.
You don't really know.
It worked.
Need to know.
It worked.
But what they want to see is if you understand that nitroglycerin will not help you with a lung condition.
Okay.
So.
You guys wanna take a break for some pizza or no?
We're almost done.
We're gonna go through a couple of questions.
Alright, this is probably the last thing we're gonna do.
Yeah, unless you guys want to do more, I can stick around. But yeah, nitroglycerin does not come in which of the following forms?
Ah, A gel.
Good job. Okay. So the other one, the transcutaneous would be the paste. Nitroglycerin can be administered by which of the following routes?
Sublingual, C.
Yeah, good. And the medications such as Viagra, Cialis, Levitra can be potentially fatal interactions with nitroglycerin due to their blank effects.
Vasodilation.
Good. Good. So what does beta-1 agonist do?
Ooh, it's gonna be lung, no, it's heart.
Heart one.
So it's going
Beta
to,
one.
and it goes with it, so it's gonna stimulate?
right? Yeah, increase, stimulate heart rate. Good, great job. And a beta-1 antagonist is obviously the opposite. After you administer the appropriate dose of nitroglycerin to your patient, he begins to have a seizure. This would be an example of
Be a side effect.
I did C, but.
Yeah, so it has
swag.
no real explained correlation to nitroglycerin. Nitroglycerin shouldn't cause seizures. Ideally, it should just lower blood pressure. So what would be the end result of what it would cause is probably just passing out if you gave them too much or they had too much vasodilation. Which term describes the interaction between two medications that causes one drug to enhance the effects of the other?
Synergistic.
Good. Valium or diazepam is categorized as the controls by the act as a schedule what medication? What drug class is Valium, guys?
4.
4, good. Oh, it is a schedule 4. And what's the drug class though?
Illegal. And-
No,
No.
Valium.
Oh, Valium.
I've
It's,
seen lots of bottles of that.
That's right, sorry.
It's 4. It's a schedule 4 controlled substance, but what's the drug class? There's 2 drug classes of schedules I told you to remember.
It's a benzo.
It's a
It's a
benzo.
benzo.
Oh.
Remember, all the PAMs are benzodiazepines and they're all 4s, okay? Opioids are 2, except codeine. Benzos are 4s. This category of medication is defined as risk of adverse effects has clearly been demonstrated in humans, therefore these drugs should not be administered. Yeah, X, good. Don't give those to pregnant people. List the 10 rights. I'm not gonna make you guys do that.
Ugh,
Thank
yeah.
you.
Can we change that to 5?
Explain the difference between enteral and parenteral.
One's around.
Yeah,
Yep.
One's internal.
yes. Okay. Any other takers? Right, so enteral is by oral route, or of the GI tract, inside the GI tract. Parenteral is referring to intravenous administration mostly. Yeah, so around the GI tract. Yeah. That's about it.
Dan, thank you.
Yes, that was awesome.
Yeah.
Please enjoy some pizza with
Yeah.
us.
We're really
Great.
funny people.
Take you up on that.
You didn't pick up on that.
We have a great sense of humor.
It's not always
Well,
appropriate, but
It's
great.
not always appropriate.
It's all good.